Good morning. My name's Alan Weil. I'm Editor-in-Chief of Health Affairs. We're very pleased this morning to be releasing the July 2017 issue of Health Affairs, which is focused on advanced illness and care at the end of life. This is a complex topic and an important topic, and we're really thrilled at the journal to be able to put together such a strong compilation of papers that cover a broad range of topics related to care at the end of life. Care at the end of life reflects the strengths and weaknesses of the overall American healthcare system. It brings great technical competency and great abilities to extend life at times when the prognosis may seem bleak. And yet, to achieve care at the end of life that honors patient preferences requires rethinking and re-engineering the healthcare system, much as is occurring in care in other domains. It requires rethinking relationships across providers, rethinking relationships between patients and providers, rethinking relationships between institutions and the providers who deliver care within them. The term patient-centeredness is used often as a goal and is a defined dimension of quality of care, and yet patient-centeredness at end of life is particularly complex and yet also particularly needed. And of course, patient-centeredness requires an understanding of the complex psychosocial issues that people face as they approach the end of life. Just saying we want to respect people's preferences, which sounds fairly straightforward, turns out to be highly complex, not just from a engineering perspective and delivery system perspective, but actually understanding what it means to honor people's preferences. And of course, this all plays out in the context of a complex and somewhat archaic financing system where, since the majority of deaths occur later in life, the majority of care at the end of life is paid for by Medicare. Medicare, of course, built around an acute care model with a hospice benefit designed decades ago, with many people trying to rethink these elements, and yet rethinking and making change happen are two quite different things. And so all of these topics come together in this month's issue, and all of them you will hear about today in our presentations. I want to acknowledge Vince Moore, who you'll hear from in the first panel from Brown University School of Public Health. He was our theme advisor. And I want to acknowledge the very significant support of the Gordon and Betty Moore Foundation that made this issue possible. Before I turn it over to Janet Corrigan, which I'll do in a moment, I do want to note that in this issue, as in many in the last year, we've been able to create a two-page folio of a data graphic that brings together important information drawn from various aspects of the paper. And as you look at the issue, I hope you'll take a particular look at the data graphic. So as we start off today, I'm going to turn to Janet Corrigan, who's the Chief Program Officer for Patient Care at the Gordon and Betty Moore Foundation. She was, from 2006 to 2012, the President and CEO of the National Quality Forum. She was a senior board director at what was then the Institute of Medicine, now the National Academy of Medicine. And she helped spearhead efforts to produce the groundbreaking reports that I know you're aware of, To Err Is Human in particular, and Crossing the Quality Chasm. I met Janet at a time that precedes even what's on her bio, when she was the staff director, executive director of President Clinton's Commission on Consumer Protection and Quality in the Healthcare Industry. So I had the pleasure of working with Janet more than a few decades ago. It's my great pleasure to turn over the podium to Janet Corrigan to give some opening remarks.
Thank you, Alan, for that very nice introduction. And I just want to thank Alan and the entire team at Health Affairs for all of their hard work on this special issue. As you know, a special issue is more than just the issue. It's all of the activities around it, like this gathering today and the infographics and the blog series. And that's so important to really communicating and getting the word out. And it came together in a very well-planned and seamless fashion. So thank you very much for that. Okay. This issue of how we care for an aging population that is burdened by chronic disease, physical, cognitive impairments, frailty, and in most situations, in many situations, have very modest financial means, is really one of the most important challenges of our time. And it's critical at this point, I think, that our country really begin to formulate a coherent policy strategy and that we pursue evidence-based approaches to delivering care to this population. And we frankly have no time to lose given the numbers of people who are, the aging rate at which the population is aging. And this is really more than delivering end-of-life services. It's really the whole last phase of life, which for most of us will likely be years in duration. And the traditional distinctions between acute, chronic, and hospice are really a very poor fit for this population. And piecemeal approaches to coverage, to benefits, and to financing will likely lead to higher per capita costs, not lower per capita costs. Not to mention the fact that the care that is delivered will be very poorly aligned with people's goals. So as Alan said, we really do need to start to rethink how we deliver care, how we finance care, the benefits that we cover for this aging population. If we fail to act and put in place some important national policies, state policies, and activities within both the public and private sector, we will very likely sit at the precipice of a public health disaster. This is a very vulnerable population with limited ability to care for themselves and without a lot of planning that's gone into that final phase of life. So the decisions that we make about public financing in particular and about how we organize care will influence and impact who gets care. And if we don't make the right decisions, many people will not receive care during this final phase of life. It will also influence where they receive their care, whether it's in emergency departments or hospitals, or whether it's in the comfort of their home, where most of us want to be. And it will influence in a very, very profound way the quality of care that is provided during those final months and years, and the quality of the death experience. These policy decisions will also reverberate throughout the economy because we all bear the burden of healthcare expenditures over the long run. But I think we can also anticipate that there will be a disproportionate impact on the many families of modest means, where stepping up to the plate and assuming the responsibilities of a family caregiver often means loss of income of the family breadwinner. These are important decisions, and they speak volumes about the moral and ethical backbone of our society. They also have implications for the likelihood of future generations, our children and grandchildren, being able to realize their dreams rather than carry the heavy financial burden of all of the services that are provided. So we're really, really happy at the Moore Foundation, and the reason for funding this special issue was really a sense that this is an important moment in time. There are going to be critical decisions that are made at both the national level and in state houses across the country. There are going to be decisions that are made in both the public and the private sector. And the more we can pull together the evidence and bring the best minds together to be able to analyze and lay out some of the policy options, we think that those decisions will be more informed and hopefully have a much greater positive impact on the country overall. So I just want to conclude with a real heartfelt thank you to the healthcare services research community, which I think really stepped up to the plate and produced just a wonderful set of manuscripts in this volume, and we greatly appreciate your contributions. We firmly believe it will have an impact. Thanks very much, and I look forward to the morning and exciting sessions ahead.
Thank you, Janet. And let me, as our first panelists come up, that's your cue. Let me just lay out the structure of the day, and as they arrive here, I'll actually introduce them, but you don't get introduced if you're not at the front of the room. It's always hard to know how to structure the complex content of a thematic issue, but the way we've set it out today is the first series of papers describe care for people with advanced illness as they approach the end of life. We then have a panel that focuses on financing and spending, including some interesting comparisons between the United States and other countries. After a break, we'll focus very much on quality and patient preference and conclude with a panel that discusses hospice and palliative care. So now that we have our first panelists with us to discuss care at the end of life, you will be hearing from Melissa Aldridge, an associate professor in the Department of Geriatrics and Palliative Medicine at the Icahn School of Medicine at Mount Sinai, Catherine Ornstein, an epidemiologist and assistant professor in the Department of Geriatrics and Palliative Medicine and the Institute for Translational Epidemiology at the Icahn School of Medicine at Mount Sinai, Laura Hatfield, associate professor of healthcare policy at Harvard Medical School, and Vince Moore, professor of health services, policy and practice, and the Florence Pierce Grant University Health in the Brown University School of Public Health. I'll turn it over first to Melissa.
Great. Thank you very much. It's a pleasure to be here. So the goal of our overview paper was to look at the epidemiology of care at the end of life, as well as some of the patterns, with the goal of kind of identifying the trends and framing some of the healthcare policy issues to debate and discuss in order to improve care at the end of life. So three of the key trends that we identified in looking over the data and the recent evidence base was first an increase in the diversity in the primary diagnosis of decedents, a rise in multimorbidity among people with terminal illness, and finally some shifts in the patterns of care at the end of life as well as in the site of death. So the first trend is the increasing diversity in the primary diagnosis of decedents. And so what this chart shows are the top 10 causes of death in the US in 2015 and their comparable amounts in the year 2000. So to highlight, of course, the highest prevalence is for heart disease and cancer, with heart disease being the highest. Although the prevalence of heart disease as the primary cause of death has declined by about 11% between 2000 and 2015. The greatest increase in both number and proportional increase in cause of death was for Alzheimer's disease over this period. And of course, some of this, as many people know, is due to a reporting bias. I think in the earlier years, particularly around 2000, Alzheimer's as a primary cause of death tended to be underreported on death certificates, which is the data source for these numbers. But also as of 2015, it is still considered that Alzheimer's disease and dementia are underreported as cause of death. So even the 2015 number is likely an underreporting of what the actual reality is. A second trend is a rise in multimorbidity among people with terminal illness. So there's a number of different definitions of multimorbidity, but if you use a simple one, which is 2 or more chronic conditions, there's a fairly high prevalence. About 50% of older adults, 65 and older, have multimorbidity, 70% of Medicare beneficiaries, and a full 40% have 4 or more chronic conditions in the last year of life. And the trend, if you look at the years between 2000 and 2010, and this is data from the National Health Interview Surveys, shows that the prevalence of multimorbidity is increasing from 37% of adults with multimorbidity in the year 2000 to 45% by the year 2010, and a similar but smaller increase for younger adults. And we care about multimorbidity when you're thinking about individuals at the end of life because it's been shown to increase both the complexity and the demands on end-of-life care. So our clinical practice guidelines focus on single diseases, which can often result in then conflicting treatment recommendations for an individual with 2, 3, or 4 such conditions. Also, those with multimorbidity are often excluded from clinical trials. So when we're assessing, say, the cost and benefit of a certain intervention, or particularly the time frame for experiencing that cost or benefit. If individuals are excluded, we really don't know what those answers are in the context of someone with multimorbidity. It can also complicate decision-making, particularly when you're talking about stopping treatments for certain conditions for someone with multiple conditions. And there's been an increasing amount of research regarding caregiving complexity for those with multimorbidity. So issues where there's complications with medication management or using medical equipment, or even the financial burden can really be multiplied for somebody with multiple complex conditions. And the third trend is there have been shifts in end-of-life patterns of care and sites of death. So one of the patterns of care that we identify in our paper and go through in some detail is a high prevalence of high-intensity care at the end of life that appears to be on the rise. So many studies look at different populations in different time frames, but if you look at, say, the last 6 months of life and fee-for-service Medicare beneficiaries, a full 3/4 are hospitalized in the last 6 months of life, with a quarter experiencing multiple hospitalizations. Close to 60% are visiting the emergency room. 40% spend time in the ICU, and close to half are admitted at some point to a nursing home. And recent evidence looks even at the last 3 days and finds that 14% are transitioning in care setting. So an individual who has been in the home in the last 3 days goes to the hospital, or an individual in the nursing home goes to the emergency room. There's been some shift in their care setting. But alongside of this, there's been a tremendous increase in the use of hospice over this period. So this chart shows for 4 different time periods the number of hospice users as well as their primary diagnosis. So back in 1992, you can see that there were about 200,000 hospice users, and it was predominantly individuals with cancer. But if you look over time, by 2014, it's up to 1.6 million individuals who are using hospice prior to death. And it's about a third cancer, with significant increases for those with heart disease, Alzheimer's disease, and other conditions. But in thinking about intensity of care at the end of life, even for these individuals who are enrolling with hospice, some of our recent work has shown that there can be fairly high hospital use even after hospice enrollment. A full 18% of individuals visit the emergency room at some point after they're enrolled with home hospice care, and 12% are hospitalized for 1 or more days. And the final trend to identify that we discuss in our paper is looking at the site of death for decedents over time. So the top part of this graph shows the number of individuals who die by setting between 1999 and 2015, and the bottom just shows the proportional numbers. So the first thing to note is that the highest prevalence is the green line, which is hospital death. However, there's been a substantial decline over time in hospital death, from about 1.2 million decedents to just over 1 million. And the other thing to note, which we found very interesting, was this increase in home death, which is the orange line, from just under 600,000 to up to about 800,000 individuals. And I think the trend there, we can think about some of the implications for this if the trend in the last, say, 4 or 5 years were to continue, what those implications are for the need for health care for those individuals, particularly in thinking about then that increase in multimorbidity and the complexity of care. And then if you just look at the subset of individuals with Alzheimer's disease, of course, the most prevalent site of death for those individuals is a nursing home or long-term care facility, which is the blue line, also increasing over time. But again, if you look at the home care line, the home as site of death line in the orange, it's also been increasing. And I think the last 2 or 3 years is a fairly sharp increase. And so thinking about how we can manage that type of phenomena going forward if the services are in place to manage Alzheimer's disease dying in the home setting. So in looking at this epidemiology and these various care patterns, I think you can think of a number of different issues to discuss. I'll just highlight some of the 2 that we identify. The first is that this changing epidemiology puts new pressure on the Medicare hospice benefit. I think the Medicare hospice benefit is well positioned to serve individuals in the home setting and address this increase in home as the site of death, as well as to deal with the issue and challenge of multimorbidity. However, we're looking at the changing, the range of diagnoses of decedents and thinking about if the hospice benefit is the best fit for individuals who have a condition where the prognosis may be more difficult to determine. It's not clear if the Medicare hospice benefit can then meet the needs of those types of individuals. And second, to better understand and then address the increasing intensity of care at the end of life, as well as the increase simultaneous with an increase in hospice use. So there's been a number of work of individuals, Joan Tino and others, looking at hospice as kind of an add-on to very intensive care at the end of life. So I think understanding this, as well as addressing it and thinking about other types of home care models, So palliative care, home care models further upstream to try to address this need and address this issue. Thank you.
All right. Okay, great. Thank you so much for the opportunity to present our research today, which profiles end-of-life caregiving in the United States. Family caregivers play a vital role in the care of individuals with serious illness and disability, and this, of course, includes the end-of-life period. During this time, caregivers may take on new challenges, including difficult decision-making and the management of pain and other symptoms. Furthermore, transitions across care settings, multiple hospitalizations, and high out-of-pocket spending may further burden caregivers. We conducted this study in order to have a more comprehensive understanding of the caregiving experience at the end of life, which is key to ongoing efforts to improve end-of-life care. And in particular, we wanted to expand upon previous research on the end-of-life caregiving experience by focusing on all caregivers, not just a primary caregiver. Additionally, we wanted to include all individuals at the end of life, not just those with individual diseases or those in specific care settings. And also, we really wanted to use prospective data collected before an individual dies, and therefore not subject to a biased perspective of the caregiving experience. So the data I'm going to show you today uses two large epidemiologic studies, the National Health and Trends Study, which I will refer to as NHATS, and its linked National Study of Caregivers, which I will call NSOC. And the NHATS is a prospective nationally representative sample of older adults in the United States. For this study, we looked at individuals who died within 12 months and referring to them as end of life. So what we find that as individuals approach the end of life, they receive more help from more people. We found 2.3 million caregivers nationwide supporting older adults in their last year of life. Now, older adults at the end of life are receiving almost twice as many hours of help per week as older adults receiving help at earlier stages of illness. We also see that the caregiving network is expanding. That is, they are receiving care from more helpers, an average of 2.5 per older adult. And finally, while the vast majority of care is provided by unpaid family and friends, we do see a significant increase in use of paid care at the end of life. With those individuals at the end of life, about 1 out of 5 of them are receiving paid help. What you see here with the shaded area is that less than 10% of older adults at the end of life are receiving paid care supported by government or other insurance, a percentage not significantly different than other older adults. We also examined the tasks that are performed at the end of life and by caregivers, comparing them to other caregivers. You can see here in the blue, these are tasks, different tasks for caregivers who are caring for individuals who do not die within 12 months. And you can see here, they're very involved in different tasks. On the left, you see personal care, those are bathing and dressing. 31% of them are assisting with this. When we compare this to end-of-life caregivers in the red bars, we see that there's increasing involvement with these tasks at the end of life. However, it varies. The columns on the right are tasks that are very health service oriented, working with insurance, care coordination, medication management. While there's some increase at the end of life, we see that they do not increase significantly. All caregivers are involved with these tasks. And finally, as we know, caregiving may negatively impact the mental and physical health of caregivers who are under tremendous stress. As shown in the blue, these again are individuals who are caring for people who are not dying in 12 months. We see here that they have they're exhausted, they're reporting they have no time for themselves, and other care-related challenges. When we compare these to caregivers for individuals at the end of life, we see that they are significantly more likely to report physical difficulty, exhaustion related to giving care, and having no time for themselves. However, on the right, you can see financial difficulty, depression, and anxiety. There's some increase, but they're minimal when we compare the two groups. We further examined the end-of-life caregivers based on the type of diseases the older adults had. This first shaded area represents caregivers of individuals with dementia at the end of life. And you can see here, they report particularly high physical difficulty. When we look at caregivers of individuals with cancer at the end of life, they are reporting the highest emotional and financial difficulty. And finally, when we look at individuals caring for individuals with heart disease at the end of life, we actually don't see that many significant differences relative to non-end-of-life caregivers. So in conclusion, the study reveals the huge reliance our society places on families throughout the course of serious illness, and especially at the end of life. Now, although older adults are more likely to receive paid care towards the end of life, the vast majority do not receive any paid help at all. We are relying on families for their care, which is often quite complex and challenging. While we found that during the last year of life, caregivers are more involved in tasks, spending more time, and we saw more negative aspects of caregiving, such as physical difficulty, we did not see consistently higher levels of difficulty across all domains. The challenging job of a caregiver is not necessarily restricted to a few months before an individual dies, and we must do more to support them throughout the often long course of serious illness. And I think this also speaks to the heterogeneity of the end-of-life caregiving experience, as shown by differences by disease type. We saw dementia caregivers really having more physical difficulty, for example. Relationship type is also important. While I didn't show these data here today, we did find that spousal caregivers, in fact, had the most challenges, more depression than other end-of-life caregivers. They were also more likely to provide care in isolation. So in conclusion, we need policies that will support caregivers throughout the course of serious illness and the end of life. And of course, this will require a multifaceted approach. Certainly, this will include expanding access to palliative care, which can help facilitate the delivery of supportive services to families earlier in the disease trajectory. We also need policies that will support paid leave for families. This is essential to ensuring that families can provide the care that we are relying on them to provide. We also find from this work that caregivers at the end of life and throughout the serious illness are involved with the healthcare system. We therefore need a healthcare delivery system that will identify and support these caregivers. Thank you very much.
I'm very pleased to be on this panel in particular because I think that the remarks that I'm going to share will very much build on what Melissa and Catherine have already presented today. I'm pleased to be giving this work on behalf of the first author of the paper, Megan Schuler, who just started a new job and therefore can't be with us today. So the point of our study was to emphasize diversity in the end-of-life care experiences of an otherwise relatively homogeneous population of patients, all of whom were diagnosed newly with extensive stage small cell lung cancer. We identified those patients in the SEER cancer registries, which span the nation, and their Medicare claims were then linked to the cancer registry data and allowed us to reconstruct for every one of these more than 14,000 patients from the time of their diagnosis all the way through until their death, the pattern of care that they received through Medicare-covered services that are facility-based. So this includes admissions to the hospital, either on an ordinary inpatient unit or in the ICU. It includes both facility-based and home-based hospice care, and it also includes post-acute settings, stays in skilled nursing facilities. So you can imagine for each person that there is a sequence of these passages through different care settings. And when they are not receiving any facility-based care that's paid for by Medicare, we call them at home. But of course, this could be residence in a long-term nursing facility for people who essentially live there and are either private pay or Medicaid paid. So for each person, as they progress through this sequence of care settings from diagnosis through death, they're having a very diverse set of experiences, which we could summarize using a bunch of summary statistics, the average number of people who are admitted to the hospital, the average number of people who enter hospice. We wanted to go a little bit further, a little deeper, so we used a technique called latent class analysis to look for major patterns that characterize substantial subgroups of patients and really paint a deeper portrait of the patterns of care that these folks are experiencing. So in doing so, we identified 4 distinct classes of patients. This is, again, just based on the data about the types of healthcare that they use, but you'll see that it also tends to separate patients into different clinical categories as well. So fortunately, the majority of people spent most of their time, again, at home, where home could mean either a residence in the community or living in a nursing facility. They tended to have the longest survival, and they had the least intensive utilization of facility-based healthcare. So again, these are probably the healthy subset of patients. 17% of people spent a very substantial amount of time both in the hospital in an ordinary inpatient unit and in post-acute care. They have very short survival of only a month. A slightly smaller subset of people quickly enrolled in hospice and essentially stayed there through the whole course of their illness, and that's where they died. And then the smallest group of people had the most intense care utilization. They spent most of their time in the ICU, and they only had a month of survival. So these broad characterizations of the subgroups of patients that we identified in the data also correspond with other descriptions of the differences across the classes. So if you look at the average across the entire cohort of patients, all of whom were diagnosed with the same form of advanced lung cancer, and you plot over the course of the time from their diagnosis to their death, what proportion of patients are in the hospital, how many are at home, how many are in post-acute care, it looks like a relatively smooth pattern of people leaving the home and going into hospice. But across the 4 classes, things are much more interesting and complicated. So this figure breaks apart the same trajectory from diagnosis to death, the proportion of patients in the 4 subgroups who are in each of these care settings. So the people who are in the primarily at home class, that's in the top left figure, they really are at home basically until the very end of life when some enter into hospice care. By contrast, the hospice group, they go almost immediately into hospice. They stay there with a little bit of hospitalization right at the beginning of their illness course. Folks who are in the ICU and in the hospital primarily, really go into the hospital and really never come out. So a very common site of death for those patients. And remember, the folks in the bottom 2 classes, the acute-dominated and the ICU-dominated class, their span of survival is only about a month. So the time scale is different across the 4 groups. So when you imagine presenting to a patient with new diagnosis of this extensive stage small cell lung cancer and trying to describe to them their care choices going forward, it matters tremendously whether this is a person who's expected to have that 10-month pattern of survival where they have a long time to get their affairs in order and make sure that their end-of-life care is in accordance with their wishes, versus folks who are being intensely, acutely managed primarily in the ICU and in the hospital. That's a very different decision setting that they face. As I mentioned, the 4 classes were identified only using the patterns of their billing claims, but when you look across the classes at other characteristics, you can identify a lot of other differences between them. In addition to the mean survival that I mentioned, with folks in the home-dominated class surviving 10 months versus 4 or 1 month in the other groups, they are also very much most likely to get chemotherapy. The site of death differs in pretty predictable ways across the 4 classes, with folks in the hospice-dominated group almost entirely dying in a hospice setting, and wide variation across the other 4 groups in terms of the place where they eventually die. And other measures of potentially aggressive versus higher quality end-of-life care differ across the 4 classes as well. There's also spending implications. As you can imagine, folks who are being managed very intensively in the inpatient setting or the ICU have much higher intensity of spending as well. Oops. So the point of the work, I think, is to emphasize that the end-of-life picture, even for a relatively homogeneous group of patients, all of whom have a very serious cancer diagnosis in common, is substantially different depending on early characteristics of their disease that put them down a path of either management at home primarily with a little bit of hospice care at the end and some early hospitalizations, versus going into the hospital or the ICU and essentially staying there through the entire course of the disease, which is a very short period of time for those patients. And I think this raises policy questions about the way that we design policies with diversity of patient experiences in mind. Thank you.
Good morning. I'm just delighted to be here and very happy to see the culmination of all the hard work of the health affairs staff and the presenters, and particularly delighted we have a number of papers, international presentations of comparative work about how international groups have actually done looking at health service use at the end of life, and also particularly happy that we have a paper on the largest healthcare system in the U.S., the Veterans Administration. As intended, these papers sort of stand alone, but they are more powerful when viewed as a whole. So it's really great that you guys are able to see all of this together. I'd like to briefly comment on my interpretation of the meta message that runs through these papers, most from the perspective of someone who's been looking at these things for a long time, since the National Hospice Study, which was the precursor of the Medicare benefit, and indeed 4 decades that I've spent looking at the prevalence of determinants of inappropriate care at the end of life. Sort of the repeated failure of policy proposals that we've observed over the last 30 or 40 years to address the underlying problem has made me increasingly impatient, but as I get older, increasingly philosophical, which is sort of what I'm going to be talking about now. The special issue papers cover the major policy issues and some proposed solutions to the challenges inherent in financing and delivery of care, whether describing cost savings associated with palliative and hospice care, training primary care physicians to have conversations about prognosis and care planning, or the need to better understand patients' preferences or treatments or comfort. These papers adopt a relatively optimistic stance regarding the impact of informed patient choice and transparency. What all these strategies have in common is that is the assumption that if people talked realistically about their prospects and preferences, or if physicians could take the time necessary to explain things clearly, patients and families would come to accept the prognosis and not seek costly treatments. They would avoid ICUs and accept palliative and hospice care earlier in the end-of-life process. There are significant barriers, however, to shared decision-making in the face of unfamiliarity and ambiguity. Simply understanding prognostic predictions requires sophisticated numeracy and lots of faith in the historical components, which most of us don't possess. Physicians' approach to practice and the communication style that they employ also greatly complicate care decisions in ways we really don't understand. Over the last few decades, improving advanced care planning has been the mechanism widely promoted to ensure that patients receive the type of end-of-life care they want. I'm doing a huge trial on this right now. Whole communities have been targets of the Conversation Project, a program to encourage families to establish an actionable plan. Since physicians are so often in the position of explaining this, there have been many programs designed to actually help and train physicians how to have this conversation better. Increased access to palliative care concurrent with disease-modifying treatment has also been advocated to allow for patients' gradual transition from costly aggressive treatments with limited chance of arresting disease progression. However, it's likely that all physicians have had more than one patient caught in the paradox of both understanding their prognosis but not being able to internalize its meaning for their own lives. They continue to live with some degree of denial and make choices as if each new sign of worsening disease is a minor setback or side effect from which they will recover. While this is probably more prevalent amongst younger patients, families of older patients sometimes play the role of denier by proxy, continuing to press for treatment long after healthcare professionals, and at times the patient, think is warranted. Since stated advanced care preferences are acknowledged to be unstable over the course of an illness, physicians are likely to be wary of making assumptions about what patients want as they approach end-of-life care decisions. Many physicians will remember a surprise remission or recovery and may be loath to propose options that preclude the same opportunity. Any indication of patients' ambivalence may lead physicians to offer treatments that might not be offered were there no ambiguity. Physicians' fear of foreclosing options may be as great as those of patients and families, so all conspire to do what the other wants. This natural ambivalence is amplified by real changes in the effectiveness of treatments for even advanced disease. Small and incremental, there are enough examples now to shift the tone of the discussion, engendering doubt about patients' resolution to forego treatment. Personalized medicine has achieved some tantalizing successes, raising hopes of patients and physicians alike, complicating discussions about palliative and hospice care. Perhaps in consideration of this, we should be more tolerant. I should be more tolerant of the slow progress advanced care planning and similar initiatives have made over time. It may not just be the inadequacy of financial incentives or the poor training of physicians that physicians receive in holding these conversations. Ambivalence, hope, and denial may all serve to alter our willingness to make definitive decisions to stop treatment and embrace palliative care. It is so much easier to fall into the inertia of ongoing treatment, hospitalization, and even ICU admission. If this is the case, our calculus about cost savings from advanced care planning, physician training, and palliative care integration may not be as large as research suggests. While research clearly points a way to reducing inappropriate care at the end of life, in the US at least, these initiatives are unlikely to put a halt to the relentless rise of disease-oriented treatment at the end of life. Financial incentives in our healthcare system conspire with this legitimate reluctance of patients, families, and physicians to give up hope for life extension. Now, I don't want to leave you on a completely pessimistic note. There is reason to be somewhat optimistic, since the changes that are discussed in this particular issue of health affairs clearly have shown that it is possible to make a really big difference. However, there's still a lot more that needs to be done, but making these changes will continue to be extremely difficult and likely slow-paced in the US. Thank you very much.
Thank you, Vince, for those comments and for the incredible role you played in making sure this issue was as high quality as it is. I often ask one question of each, but I'm going to, following on Vince's point that the whole in this issue really is greater than the sum of the parts, I have a question I'm going to frame to all of you and then open it up to those in the room. I'm struck with these descriptive papers of the complexity. That's of the story in some respects of all of them. The challenge then is, what do you do with complexity? Is the complexity, does it lead us in a direction? And I guess the focus that I'm going to have is, I see multiple comorbidities, I see complex home situations, I see even within one disease, lots of different trajectories. One way to look at this is to say it's a heterogeneous population. People have different conditions and they have different preferences, and so when we see difference, we should say difference is difference. Another is to say there's a lot of complexity and difference here, but people are not having their needs met. And my question is, how do we take these descriptive, very rich descriptive pictures of what people's circumstances are, how do we figure out whether that complexity is actually yielding what it is that people want? Or do we just have a big mess on our hands and a lot more information about how complex it is, and then we say, you know, we kind of go from there? Who wants to take on that very simple little question? Come on, someone has to rise to the...
Well, I think there's a great role for qualitative research in this area. So my colleague Nancy Keating and her junior colleague Alexi Wright have done interviews with caregivers and asked, did you get what you wanted? Was this what you had envisioned for your loved one? Were you satisfied with the care that you got at end of life? Because particularly in our study, which is analysis of billing claims data, there's absolutely no way to know whether folks who are spending all of their time in the ICU wanted that or didn't. So I would like to see more qualitative and interviewing work in this area to ask people who have these diverse experiences whether it was aligned or not.
I think actually what we need is flexibility within our healthcare system and the services that can be offered. I think what we see with hospice care is a tremendous increase in demand for hospice care and demand across all types of diagnoses. And so I think kind of meeting that need in a flexible way is what's most important. And for individuals who may not fit within the hospice benefit or enroll as early as they might want to, we need greater emphasis on other types of home care, palliative care models prior to hospice, such that that transition can be managed better and meet all these different complexities and needs and comorbid conditions.
I think with respect to families, we have to embrace the heterogeneity, and that will actually help us move forward by accepting that situations are complicated and not all families want the same thing and work together in the same ways, and we have to accept that.
So I guess as a sort of non-physician, non-clinician, but who's been looking at this for a long time, there is great variation from area to area geographically. There's great variation from provider type or provider group or healthcare system type. The VA is quite different than other places. Even though there's heterogeneity at the individual level within each one of these groupings, it is possible to think of a universal sort of notion of at what part of the decision tree do you want to be? Where are your priors? Are they just a little bit more hope and you're going to want to go for that third line of treatment, whichever type of disease you have? Or is there a certain difference in the expectations under certain circumstances? And that's a discussion we haven't really had as a society, and I think it transcends the heterogeneity because it's there as a meta notion within each individual as well as within each disease type.
I'm going to turn it to you all, and we're on camera, so wait for the microphone and please introduce yourself.
Sure. I'm Jane Tilley with the Administration for Community Living, and I'm wondering when you're
Jane, can we? We're not picking you up. Sorry.
Jane Tilley from the Administration for Community Living. And I'm just wondering if you all could talk, whoever wants to, about how the use of services might vary for people who don't have family caregivers, older people living alone. I'm guessing they would have more intensive use of institutions, but I don't know that for a fact. Any thoughts about that?
I'm really glad you brought that up because really we're presenting this information about, the vulnerability of individuals who have families, and certainly there's individuals who do not. And I think that is a real concern in terms of where they are and who's supporting them in the community and why they cannot stay in the community because of that. So I think that's a real issue, and I think as we think of changing demographics in this country, that it's certainly of greater concern.
So let me just respond a bit. The population of people who are residing in nursing homes on any given day who are long stay is less than 1 million now. And most of those people have stayed for a year or so, but the duration of people's stay, even those who are long stay in nursing homes, is continuing to drop because people are delaying their entry into nursing homes. And so it's the nursing home, or now the assisted living facility, that is actually that sort of place of last resort for individuals without much of a family support system. but they too are not staying in those settings all that long alone. So that is going to be a really big challenge. But as Catherine suggested, right now, as a society, and probably Europe as well and throughout the rest of the world, families are the mainstay of this activity.
I'm Dr. Caroline Poplin. I'm a primary care physician. My question is about palliative care. It sounds from what you're saying that palliative care means you're giving up some kinds of more aggressive care. I don't see any reason why palliative care, keeping people comfortable, that shouldn't be part of care along the continuum. You're making it sound like it's an alternative to.
I'm assuming that's referred to me. That's
No,
not,
no.
That was
To
not
all
my
of you.
that was not my intention in my remarks
Okay.
at all. It just so happens that as the evidence from the research that's done to date on the introduction of palliative care suggests that as palliative care is increasingly received at the individual level, the likelihood that people receive more aggressive treatments on the medical side, sort of anti-tumor or what have you, tends to decline. And so there is, under those circumstances where palliative care is offered, there is a natural mixing that occurs.
Well, do you think
I'll just say that having tried to harmonize more than 20 papers, there are a lot of terminology issues. This is always the case, but I think it's particularly so in this domain. Advanced illness, end of life, palliative, bring up lots of images for people, and one of the challenges, and I know the foundation is working on this on their broader agenda, is, and others as well, how do you talk about this issue in a way that doesn't immediately make people have assumptions about any of a number of things? And I know, and of course Diane's here, the palliative care movement has struggled to break out of the assumption that you just described, even though substantively people know that it's not either or. It's just, these are images people build in their minds. And so there's a communications role here as well, and actually that topic will come up more as we go on. We have time for one more person back here, and then we'll move to our next panel.
Hi. Hello, my name is Melissa Williams, and I'm with the National Patient Advocate Foundation. My question is for Catherine. I was wondering in your research if you could discuss just a little bit about the mean age of caregivers as well as the gender and what the impact of, I guess, what their employment status was with, as a result of caregiving for patients at end of life or with serious illness.
It's in the paper.
Of course, I don't have my paper in front of me, so I'm going to estimate everything incorrectly, but you can look at those details. We do find that there are more women providing care, and what's interesting here, but it's not all women. That's changing, right? And I think what's interesting here, what we're finding is we're not just seeing spouses, and a lot of research on caregivers had really been limited or practically, we can talk to spouses often, and we see here we have daughters, sons more so, and we are seeing a significant percentage, I think it's around 50%, that are working while providing care, which is really an important issue and speaks to the sandwich generation concept that I think is real. I certainly can testify to it.
Great. Please join me in thanking our first panel. I would ask our next three presenters to come up, and we'll go directly into our second panel. We have three papers that focus on financing and spending, including, as I noted at the outset, two of which have some comparative data globally. We'll hear from Martina Orlovich, a postgraduate researcher and PhD candidate at the Institute of Global Health Innovation at Imperial College London. Elaine Kelly, senior research economist in the public finance and pension sector at the Institute for Fiscal Studies, and Julie Bynum, associate professor of medicine at the Dartmouth Institute for Health Policy and Clinical Practice of the Geisel School of Medicine at Dartmouth. We'll turn first to Martina. It's coming. There we go.
Hello, everyone, and thank you very much for the opportunity to open this panel and present the work that I conducted with my colleagues from Imperial College. As you can see, today's topic that I will talk about is the analysis of end-of-life care, out-of-pocket spending, and place of death in 16 European countries and Israel. We are all aware that population aging, a phenomena experienced in many countries, has many social and economic implications. The proportion of people who are 65 and older is growing at an unprecedented way, and the situation in Europe is no different. In light of this, we are faced with many challenges in the context of an aging population, how to provide high quality and effective end-of-life care. This motivated us to examine what are the differences and similarities among European countries and Israel, and we wanted to do that by examining data from a survey of health, aging, and retirement in Europe, or in short, SHARE. So care at the end of life is complex, just because it is provided by a mix of providers, private and both public. It is a subset of a long-term care, and therefore it is influenced by its organization, financing, and provision. So two main supply and side factors that are affecting end-of-life care are financing mechanism of the long-term care, and therefore end-of-life care, and also the social support they receive in the type of informal end-of-life care. In light of this, we formulated a series of hypotheses on how the funding structure of the long-term care system and individual patient characteristics affect individual pathway at the end of life. So depending on the prevalent source of funding, we classified European countries into two groups. Here on the right, you can see the countries where end-of-life care is predominantly publicly funded, and mainly those are the Northern European countries and Germany. While on your right, you can see the group of countries where end-of-life care is predominantly privately funded, which accounted all the other countries that were analyzed. So descriptive statistics of our data show that there is actually substantial variation among European countries. More generally speaking, Northern European countries utilize more formal long-term care in terms of nursing home care, paid home care, or hospice care, and they also have a higher proportion of out-of-hospital deaths than those at the south. Then we utilized logistic regression to estimate a series of equations to determine what are the determinants of dying in hospital, at care home, and at home. And here we found that funding structure of the long-term care system has an important impact on the place of death. So in countries where end-of-life care is predominantly privately financed, individuals are more likely to die in hospital. Same applies for those who are living alone and those who are younger, because they're receiving a higher intensity of care. As a difference, individuals that come from countries where end-of-life care is predominantly publicly financed are more likely to die in a care home. And lastly, when we analyzed the home, we found that funding structure is not as relevant as for the other sites of death, but the presence of a long-term illness, such as a cancer, could be an important factor in dying at home, just because patients also have a longer time to plan what is happening. Our analysis of out-of-pocket spending also revealed interesting findings. We found that richer countries tend to have higher out-of-pocket spending, which could be the fact because they're utilizing more formal long-term care services. These services, compared to the acute care setting, tend also to have higher user charges. In Europe, most hospital arrangement or acute care services don't even have a cost-sharing agreement. So considering the different burden for the patients, there is a higher propensity to be admitted in the acute care setting at the end of life, especially if you're coming from the countries where end-of-life care is predominantly privately financed. What our study did not include is the out-of-pocket spending analysis of informal care, which could in the end maybe lead to actually higher out-of-pocket spending from the countries where the end-of-life care is predominantly privately financed. And to recap my presentation, I wanted to emphasize that we demonstrated the impact of the long-term care structure on the patient pathways in their last year of life. So the countries where long-term care is predominantly publicly financed, they're utilizing institutional care as a substitute for hospital care. So relieving the cost burden to the patients will incentivize more people to use these forms of care, and also it could lead to reduction in the unplanned admissions, which in the end could turn to the lower cost to the societies. So the main message is that investments in the long-term care pay off, but of course is a challenge to acquire additional resources to collect the money to provide those services on a state level. This is particularly relevant for less wealthy European countries in the context of austerity and the crisis to collect these services. But also there is a message from Europe for this country where mostly long-term care is also privately financed and many people remain uninsured because there is a high cost of these premiums. So investing in long-term care could actually lead to better quality care, better use of resources, and in the end, lower burden to the society. Thank you very much for your attention.
Okay. I'm very pleased to be here this morning. I'm very pleased to present this paper on behalf of my many, many co-authors in 9 different countries. It's given some health affairs a bit of a headache. I apologize. Okay, so high medical spending at the end of life has attracted much academic and policy attention across the world. But efforts to quantify that spending have typically focused on a single country, a single condition, or a limited range of services, and in particular on hospital care. We examined medical spending in the last 3 years of life using administrative data in 9 different countries. In doing so, we attempted to address 2 questions. The first is, how large is medical spending in the last 12 months of life, kind of mirroring many of the existing estimates of end-of-life spending, and also in the last 3 years of life, taking into account the increasingly importance of chronic conditions that were discussed in the previous panel. The second question is the US an outlier in end-of-life spending in the same way that it is in terms of total spending? I'm going to start by discussing spending in the last 12 months of life, where the existing evidence has come from. Now, while I said that we have good quality data from 9 countries, we do, but actually in terms of a broad measure of medical spending that includes not only hospital care, but also pharmaceuticals, professional services, and long-term care, we're limited to 5 countries, which I'm going to focus on for the purposes of this presentation. Those are Germany, the Netherlands, Denmark, the US, and Taiwan. Now, the US spends the most on end-of-life spending, so we see that in the US, the average cost per person in the last 12 months of life is $80,000, 2014. Now, that's more than any other country, but you should also bear in mind that the US spend more on all types of healthcare. So if you take the total amount spent on those in the last 12 months of life and divide by total aggregate medical spending, the US falls to the bottom. So 8.5% of total US medical spending is accounted for by those in the last 12 months of life, and that compares to sort of Taiwan, which is at the top of our range, at 11.2%. So You spend more in absolute terms, but relative terms, not so much. The second thing to notice is the composition of spending, which has been another theme of the talk so far. So in the US, a little under 40,000, so a little under a half, is accounted for by hospital spending. So more than a half is accounted for by out-of-hospital spending. And the story is pretty similar across our other countries. So either the majority or at least a substantial fraction is accounted for by out-of-hospital spending, which means if you really want to understand the costs of end-of-life spending, it's important to look beyond the hospital. Another reason why it's important to look beyond the hospital is that you see that there is substantial variation across countries, which Martina highlighted just now. But actually, there isn't a very strong correlation between sort of amount that's spent in hospital and total amount that's spent. So if you just compare Denmark and the Netherlands, you see that the Netherlands spends they spend almost exactly the same, just over £60,000 $60,000 per person in the last year of life, but the Netherlands spends much less on hospital care than Denmark. So in fact, extrapolating from how much is spent on hospital care could be quite misleading. Now we're going to look at the last 3 years of life. And here we find that pretty much in all countries, the amount spent on those in the last 3 years of life is approximately double that of those spent in the last 12 months of life. Again, the US spends the most in absolute terms. However, again, if you divide by total US medical spending, the US again sinks to the bottom. So the US spends just under 17% of medical spending on those in the last year of life, compared to, again, 24.5% in Taiwan. Okay, so this figure is showing medical spending as a share of GDP, both for all medical spending and for spending at the end of life. And here we see that the US spends 1.5% of GDP on medical care for those in the last 12 months. Then you add another 1.5% of GDP for those in the last 3 years, net the last 12 months. Now that is for sure greater than other countries, but what's really dominating here is that the US spends more on all types of medical care at all points in the life cycle. So if you divide that 3% by total medical spending, then actually the US spends a lower fraction of total medical spending on end-of-life care, even though the US spends more in total. So to conclude, dying is expensive, but the share of the population that die each year is small. So actually, say, reducing spending at the end of life by 10% isn't going to have a massive effect on overall spending or the increase in medical spending. However, as we've heard, there may be other reasons why you want to change how you provide end-of-life care, both for preferences and for patient welfare and so on. Spending on those in the last 12 months of life range from 8 to 11% of medical spending. Spending in the last 3 years was approximately double that in the last 12 months. Now, what we interpret that as saying that costs associated with the end of life extend beyond the 12 months. They extend beyond sort of futile attempts to expand life expectancy. And what it really shows is that chronic conditions are important, chronic conditions are expensive, but that chronic conditions are also associated with shorter life expectancy. Finally, the US, as I've emphasized, the US end-of-life spending is higher than elsewhere, but that largely reflects higher spending at all points in the life cycle. And it's below average and towards the bottom relative to total medical spending. Thank you very much.
Good morning. I'm really pleased to be here. My name is Julie Bynum. I'm from Dartmouth, and I want to thank the first panel because I think you actually set up what I'm going to say really quite well, and particularly the comment about family caregivers and sandwich population, because I'm actually of what I call the club sandwich generation. I have, until recently, had my own children, my mother and my grandmother, who very recently just passed away at age 95. So this topic actually, and a lot of the comments that have already been made, are really important to me because I think it's critical for us to think about what if we say people might avoid hospital and acute care use, asking what the alternative is. What are we offering in the community and otherwise that can support people to have the kind of end-of-life last 2 weeks, 3 months, 1 year that they actually want as they're declining? So this paper was important for me because the dually eligible population is interesting. The fully dually eligible population actually has access to paid long-term care services in their own homes and communities through their financial structure. So they become an interesting population to look at. Additionally, people focus a lot on high-cost beneficiaries and high need. And I would say the high-cost dually eligible population are most profoundly so because they not only have high medical costs, but also high long-term services and support needs. Yet, as people describe this population, they often say the dual eligibles, as if it's one population. And in fact, it is not one population. It is a heterogeneous group, message that keeps recurring. And we really try to take advantage of the heterogeneity within that group to try to learn from both people who are living chronically and long-term with disability, who are dually eligible, compared to people who may have a different trajectory, who are declining with disability and need for long-term supports on the path toward dying. So that's the sort of framework of what we're trying to do in this paper. And we also defined high cost not as high cost to Medicare or Medicaid, but combined Medicare and Medicaid, because we believe that the line between what's acute and long-term care starts to blur when you have people who are profoundly ill and seriously ill living in the community or in nursing facilities. So what we did was take Medicare and Medicaid data linked for a population of in 2010 and 2011 for 36 states and in DC. And we not only described the service use of what this high-cost population looks like, but also followed them for 1 year to see what happens to them. And that's where we get into some of the questions about what we're doing for palliative and end-of-life care for these very high-use people. So to start with, if you take the top decile of combined Medicare and Medicaid expenditures in 1 year, the average medical expenditure is close to $140,000. And the bulk of that, or the majority of that, is Medicare spending. The ratio of Medicare to Medicaid spending is 1.13. But when we start breaking this up, I want to see a couple points here. So the older dual population, the people who are 65 and older, and duals often are people, many times are people who have aged into Medicare spending, and I think many people think it is really Medicare spending, Medicaid spending, the long-term nursing home spending that drives the high cost in this population. But this data shows that even among the older 65 who live in nursing homes, Medicare spending is actually a greater proportion of their total spend. That's even more so true for the community population. When we go to the under 65 population, we find the same thing for the nursing home population. Medicare spending is still dominating. It's not until we look at the community population of people under 65 who are dually eligible and high cost where we see Medicaid dominating. So this really reflects some important distinctions between the differences in these populations. The younger duals living in the community have a low number of chronic conditions and have profound disabilities, developmental or otherwise, living in the community, while the other three groups are characterized by having multiple chronic conditions and heavily using the hospital and post-acute care world, in addition to having their long-term care use. So what happens to these different groups over time? So this is a figure from the actual paper, and since you likely can't see this from the distance, I'll just summarize. What we find, in fact, if we take those high-cost dually eligible beneficiaries and we look forward a year, what has happened? More than half of the people over 65 have died. So they are high cost at a point in life when they are on the trajectory toward death, while only 30% remain high cost for the second year. When you look at the younger than 65 population, in fact, 25% of those who live in the nursing home, which admittedly is a small population, it's only 8% of the total, die. But the younger population, only 15% die and 70% remain high cost. So this is really an important point for our discussion today. If we're thinking about seriously ill people who require both community supports and medical care dying, and the path toward dying is an important contribution to what that care looks like, particularly for people with multimorbidity, which characterizes both the over 65 in the community and nursing home and the younger than 65 in the nursing home. So how do we want to think about this? One of the things we did in this study was to say, well, you know, many people who've written about high-cost beneficiaries, high-cost, high-need, they're predicting who's high-cost. And honestly, it's hard to think about what you do to moderate or mitigate or improve the case for people who are high-cost. But thinking about people who are highly likely to die, we have lots of models of care out there, in palliative care and otherwise, that might address some of those needs. So we actually modeled that you can predict who's likely to die, just to make the point that from a policy perspective, we really can think more about not just who's high cost, but think about the likelihood, the trajectory of care, because most of the people who are high cost and over 65 are not likely to remain high cost. They are likely to die. And those costs are largely in Medicare. I skipped over a slide because I wanted to just say that one of the differences we learned by comparing the younger duals to the older duals is that the older duals tend to use less of the home and community-based services than the older duals. And that suggests an opportunity to us, whether it's because people aren't recognizing their disabilities and need for long-term services, supports, or other reasons. We find that the older duals are using Medicare-based home care to a much larger degree than the younger. And home care through the Medicare system is meant to be episodic. It is not to be a long-term support. And so that seems to us a real opportunity for the future. The policy implications of this are that we really think, if we think more about predicting who, among the high-cost people who are likely to die, and catering their services, in accessing home and community-based services earlier for them, we may be able to offer them an opportunity to do something other than the acute care setting. There are corollary lessons for the younger 65 that I won't go into today, but I encourage you to look at some of the details of the patterns of care among this population who actually does have access to paid services. Thank you.
So once again, these are terrific papers, and they're very complex, and I want to ask a question, don't read the slide, that cuts across them, which has to do with the way we think about the services and the way you, in each of these papers, divided them up. On the one hand, there are service lines, long-term care, home-based care, living at home, hospital, and then there are people. And people can be enrolled in Medicaid or Medicare or in various programs that differ by country. And I'm trying to understand, particularly when I look at this globally, because I'm more familiar with the divisions, the programmatic divisions in the US, the degree to which the differences across countries that were presented in the first two papers reflect not just the public-private distinctions that you described, but also the degree to which programs are oriented towards people or by service. And so I wonder if we could start with a little bit of an understanding of how the access to these services differs in various countries, whether it's by service or by population. I realize you got a lot of countries covered, so I'm not asking you to enumerate it by country, but how you think about those distinctions. Can you start us off, Martina?
So in Europe, what we found is that those at the north started much earlier to plan for the long-term care, and they were more affluent. So they were able to better afford the long-term care services. And that's why I also find your finding very interesting, where their hospital care is not as intensive in the, for example, other European countries. In those countries at the south, they don't really have the other alternative to the long-term care. So it could be wait until the end and then be admitted in the acute care setting. And that is why there is also a higher spending in the acute care in these southern countries. But what is also interesting is the people's preferences. Europe is kind of the size of the US, but it's quite different because, for example, those people at the north, it's quite acceptable to put your parents in the nursing home and put the responsibility of care for these people at the welfare state. Well, those people at the South, they also have they're not really keen on using these services, and they're more likely to, they count their family to be responsible for taking care of them while they'll die. For example, Greece was very interesting because it's affected with all this crisis and austerity, and we are all the time talking how we want to place people to die at home. And actually, they had around 60% of the people dying in a home setting in Greece. And when I investigated a bit more detail, asking other Greeks why is like that, and they said that it's quite common to die at home, and putting your parent in a nursing home is considered something what you wouldn't do if you really take care of your parents. So these differences in how people perceive end of life was also very interesting.
So our countries were very heterogeneous in how they sort of funded and provided sort of healthcare on one side, which would include the professional services and the pharmaceuticals, and kind of social care on the other side, which would include the long-term care and the home help. So I'm going to speak on the UK experience where I actually have more information, but we have a system where we have a kind of universal healthcare system and a social care system which is privately funded. Now, we're looking to reform that, but you see the problem with that is that the incentive, therefore, for people who are perhaps poorer but don't qualify for the means-tested benefit is there's a tendency to substitute private social care for public hospital care. So we have a much higher share of sort of 80 and 90-year-olds in hospital than they do in the Netherlands, where everything is funded through sort of mandatory health insurance. Germany, on the other hand, sort of about 10 or 15 years ago, introduced a social care sort of insurance system, but that was relatively easy in the context of a health insurance system, so the two can kind of work together. Now, the problem comes when one system is funded and organized in one way, and the other system, the social care system, is organized in a very different way.
And that is the U.S. system. So, Julie, you surprise, surprise. Yeah. So, talk a little bit about the implications of that division from the perspective of your work.
So, we were trying to be a little provocative in this paper by saying, let's look at combined Medicare and Medicaid spendings for exactly the reasons that you're talking about. We think about healthcare the way we pay for it, rather than how people use it. So the pay lines are what define what we do, rather than what people need and want. And that's why the dual eligible population is so interesting, because in fact there is federal payment for both sides of that, yet our research doesn't tend to reflect the combined nature of the care, because frankly it's complex, it's challenging, and it's difficult to think about. So Martina's comment about Greece is really interesting, because I think it's hard to know what people's preferences are independent of what their alternatives are for care. We can say the Greeks actually prefer to care in the home, but perhaps there are financial structures, family structures, economic structures that make it feasible for people to be home or want to be home and act on that, and no funding otherwise. So I think the reason this becomes so thorny for us all is because you cannot think about care for these people who are on the trajectory toward death, independent of what's going on in their families, social structure, finances, and caregiving, and independent from the financial systems. And our world tends to want to break these things apart rather than think of them as an integrated whole. So I don't think I'm answering your question, except that if we did start to think about designing, and the dual eligible programs where people are trying to integrate care at the state level have a fabulous opportunity to really start thinking about this from the perspective of people and how they move over time through healthcare. And I would encourage and hope that programs that are doing that would share the nuts and bolts of what they're doing, because what I found was it's very hard to find specific examples of how groups are doing this, because I know there are some, but they're not talking about it broadly with a wide community, and I don't think any of us can learn from it until those stories come to the fore.
Questions from the audience? Let me see if anyone other than our theme advisor wants to. We'll start back here, and then I'll come to you, Vince.
Thanks. I'm Ben Tudor. I come from the provider side, specifically looking at post-acute services and combinations between acute and post-acute care. And so my question is, what opportunities do we have in the U.S. to fuse acute and post-acute services, specifically amongst this dual-eligible population, to better manage the complex care that's brought forward by these patients with multimorbidities?
So I'm assuming this question means how can we, if people are in these settings, how do we better adapt what we do to meet their needs? And one of the things that I would suggest is to actually use those settings as an opportunity to target the population who needs palliative care, to find them. One thing we can do is do mathematical modeling to predict who's high cost, or mathematical modeling, there's all sorts of machine learning going on to predict things about population and population segmentation. But if we actually use the settings of care where we know these people are likely to be, which are nursing homes, hospitals, post-acute care, particularly home care, if we want the community people, to identify people who are likely to require these ongoing services and try to connect them and transition them to stable, non-episodic home-based care. The episodes drive further episodes because once the episode ends, you hit crisis and you start the cycle all over again, as opposed to having a stable home-based situation.
I just have to add, even the term post-acute care, which has all these ties to reimbursement and Medicare and different payment rates than for people who need ongoing care, which exactly speaks to Julie's point. Vince, the floor is yours.
So just two comments. Actually, the European papers were great. And what was interesting about that is you may want to take into consideration from country to country, there's also very different pension and retirement ages, which make available social support for caregiving from families. So Greece's retirement age and pension system is quite, well, has been up until recently, quite a bit different. And the same heterogeneity exists in the US. If you look at Medicare, Medicaid spending for the dual eligibles, nursing home versus home and community from state to state to state, you see radical differences, and those are not by accident. Some states choose to spend, even though that's eligible, and some states choose to push as much as possible over to the Medicare to federalize their long-term care obligations. So,
any reaction?
So on the Medicare, Medicaid question, I totally agree. So one of the things that was very challenging about doing these papers is all the states are very different. So we actually took the highest cost decile in each state rather than tried to use a national, because the state spending varies wildly for the Medicaid populations. But you were pointed to something that was exactly what we would hope to get to, was where are these trade-offs, these blurs between Medicare and Medicaid, and if we continue to think about these two programs as separate for these populations, I think we'll miss a lot of opportunities because they are in some ways either cross-subsidizing or substituting for each other. And we really do learn a lot by looking cross-nationally to see my experience with the UK international work I did is that the whole concept of post-acute doesn't exist because they just stay in the hospital, right? So it's that we had to count both our post-acute days and our hospital days to look anything like a hospital episode for the UK. So there are important other aspects to understand by looking at the different systems and how they're structured.
Yeah, and actually, let me just close with a question to Elaine and Martina that follows up, Julie, on what you just raised, which is there's this consistent theme of sort of the substitution opportunity for social home supports, long-term services and supports, and hospital, and there's difference across of that in around the globe, as both of your papers discuss. And I guess my question is the degree to which that appears to be a conscious choice, a policy choice, or is an artifact of either public-private differences or historical coverage, financing models. I mean, when you have a substitution, you can either just sort of live with it or you can tweak it. And I'm just curious the degree to which that that kind of substitution is known and discussed openly, and the policy is made openly, or if it's just sort of a historical artifact.
Well, I think in the beginning, for some countries, this is, let's say, feasible in the upcoming years, but for some countries, this still, I think, remains as a message. And I would specifically refer to the Southern Eastern Europe and some Central Europe, where the decision-making process is quite different than the rest of the Europe. We now hear a lot about patient autonomy and patient-centered care, while I think in these areas, this is still message that hasn't reached the families and the patients because they liked more paternalistic decision making, and therefore I think there is still a lot to be done to change what people think of the end-of-life care and what are the substitution things to really enable that institutional care would subsidize the hospital care. Because I think that a lot of people in this country still perceive that the highest quality care would actually be provided in the hospital setting, and receiving everything that is possible kind of says that you also care for these people and the system does everything that it could be done for those patients.
So again, I'll refer specifically to the UK context because that's where I sort of know the most, but it's known very well. It's discussed at length by politicians and the press. So this is the substitution between social care and hospital care, and particularly bed blocking, where you have a whole lot of 80 and 90-year-olds in the winter in NHS hospitals, which means basically they have to shut the doors and have to stop operations, and that's discussed all the time. The challenge is, what do you do about it when you have two sets of institutions? Changing those institutions is both going to be extremely expensive, but also extremely controversial. Now, the idea, there's no way that you could put a proposal to the British public saying you have to pay for the NHS. It might happen through the back door, but making that proposal or changing social care, it's one of those. I've spoken to politicians about that, and they just said, that's off the table. You're going to have to tinker around the edges. So we have these institutions, they're historical artifacts. The question is, what do we do? What do we do about it?
Please join me in thanking our panel. We have a tremendous amount of more material for the day, so please let's take a break. We're going to keep it to 10 minutes so we can move into quality and care systems. Okay, we are going to get started. We have two more panels and a lot of great papers to continue to present. This group of 5 papers covers a range of topics related to quality of care for people with advanced illness and approaching the end of life, as well as patient understanding and respecting patient preferences. We'll hear from Joan Tino, who is board-certified internist and was a hospice medical director for 18 years, is now at the University of Washington on the palliative care consult service. Robrecht Deschray is a doctoral researcher at the University of Brussels in Belgium. Kate Kortright is instructor of medicine, pulmonary and critical care at the Perelman School of Medicine at the University of Pennsylvania. Rochelle Bernacki is associate director of the Serious Illness Care Program at Ariadne Labs. And Judith Lucas is associate professor in the Department of Community and Behavioral Health at Seton Hall's University College of Nursing. We'll hear first from Joan.
Great. Thank you very much. I think as you go throughout the day, you're going to hear some very similar themes to the presentation. And I'm going to take us back to Melissa's paper a little bit and remember, who's the population that Medicare was created for? It was farmers in the Midwest who are waiting for their hernia repairs. Who's the population that cares for now? Well, it's a frail older woman after 10 years of taking care of her husband who now is left to be cared for by her children, or as Julie so aptly said, the new sandwich generation. I think the other thing is we talk about this statistic of 5% accounting for half of that spending. But behind that statistic, we have to realize there is a lot of heterogeneity. Please don't oversimplify that statistic to assume that they all are dying. Rather, some will have improved health, some will have sudden death, and for many, there's a prolonged period of living with functional impairment where medical decisions must weigh quality versus quantity of life. So rather simplistically, the healthcare you pay for is the healthcare you get. We're in the midst of a transition from volume-based incentives that pays for another day in the ICU, another day in the hospital, another procedure, to paying for value. Now, the complexity in that, as we make that transition, is we don't want that transition to go from paying for more care to paying for less care. And indeed, one of the things we point out in this paper is a key lesson of the Medicare hospice benefit. And that key lesson is we want to make sure that as we rapidly expand these programs for serious illness in the community, that we also have transparency and accountability. We should take lessons from our friends from the UK with what happened to the Liverpool pathway. If you lose the public trust, you really can lose the public trust. Sir? No, this is the second time that this happened to me this year.
So apparently we have to evacuate the building. I'm sorry, I don't have any more information than that. Well, I'm sorry for that interruption, but I think given how full an agenda we have, I'm going to just turn it right back over to Joan, and we're going to try to pick this up without missing a beat.
So now that we have the ceasing cliffhanger, so I think, you know, before we started to try to evacuate the building, we were talking about the Medicare hospice benefit. And I think, you know, as we developed the Medicare hospice benefit, we didn't have a set of transparency and accountability in place. And we recently had some concerns with lack of visits in the last 48 hours of life. So I think as we, you know, innovate in our healthcare system, which is really good, we want to make sure that we have the appropriate transparency and accountability to ensure the public's trust. Oops. I got bad news. The slide's not working now. Oops, there we go. Okay, so in this emerging population of persons living with multiple chronic illnesses, preferences matter. So we talked about two prototypical cases. If you have a 49-year-old who's walking down the streets of DC, has an acute MI, is transported to GW Hospital, 99% of those people will want aspirin. But if I show you my prototypical 89-year-old with stage 4 lung cancer, some people will want to go on to a second line of chemotherapy. Some people won't. Preferences really matter. The only way we're going to really measure that is not by whether it occurred in the EHR, by talking to consumers, either that patient or their family, about whether communication was sensitive about prognosis. They explained treatment options. They allowed people to ask all the questions they felt needed. And then healthcare providers helped that patient and family to clarify their goals of care and then develop a care plan that honors those preferences. An emphasis on that. We focus too often on developing the goals, but not enough on focusing on what the care plan is to accomplish those goals. So as we design an accountability system, we highlighted two really important things that we've heard time and time again. In Julie's presentation, we heard about the problems of creating silos of care and having one set of care for social purposes, one set of care for medical purposes, or our wonderful system of post-acute care where you keep on transitioning from one place to another. You're almost like a hot potato being handed off from one section of the healthcare system to another. We don't want quality measures to create those silos of care. I think the other thing is we've been really good at developing quality measures. Parsimony is really needed here. We really need to think carefully about what's important, and then also what's easy to get from utilization data may not be the right answer. I think one of the things we heard with the heterogeneity around the trajectories of cancer care is not everybody will follow the same trajectory. So not everybody who has a 3-day hospice stay is really a bad event. People die of catastrophic events. You know, for example, when we studied short hospice length of stay, we found 1 in 5 people, the short hospice length of stay was because of a catastrophic event that resulted in that short hospice length of stay. So there are challenges that we need to think about. We need to think about what to do with programs that have small numbers. We need to think about how the system may be gamed. But really what's important in my residual message to you is we need to start thinking about this now. We can't wait 15 years into the Medicare hospice benefit and say, let's start focusing on what quality is and be behind the game. It's really important that we develop an actual accountability system now. And I'll close there. And by the fact that we had a fire drill, I'm 3 minutes ahead of time.
Good morning, everyone. Thank you for having me here today. So my name is Robert de Schreyer. I'm from the University of Brussels in Belgium. I want to bring 4 points to your attention today. So the first point is that monitoring quality of end-of-life care is a public health priority. I think it's already clear from the previous presentations. What I mean by this, actually, in this presentation is a little different. We mean quality of end-of-life care monitoring on a population level, so not by individual patients, but on a more global level. The second point is that available administrative data on the population level provided a unique opportunity to do so, and we're going to illustrate in this presentation how it can be done, for instance. The third point is that we developed quality indicators to evaluate appropriateness of end-of-life care using such data. So the quality indicators are the major tool to enable the use of the administrative population level data. And a fourth point is that this monitoring tool provides a possibility for benchmarking, for setting standards, and for informing policymakers. So first, small situation sketch. It's actually a little abundant maybe, but at the moment we're experiencing increasing numbers of people dying from suffering from life-limiting disease at older age. And at the same time, we have evolutions in medical technologies that keep increasing the options for life prolongation. So this challenges us to also increase the quality of life, especially near the end of life. And to guarantee this quality of life, especially to keep the focus on quality of life, we need monitoring on the population level of this quality. In Belgium, we have a very specific situation about administrative databases, and this illustrates how it can be done, the quality measurement on a population level. So we're a European country with 11 million inhabitants, and every citizen is obliged to subscribe to health insurance. The health insurance organizations keep track of all healthcare data reimbursement. All treatments and medications are included. This means that the health insurance provide actually data on the entire population. Every Belgian citizen is in there with every treatment and medication that is reimbursed. These data are currently available for researchers, and we obtained them, and we linked them also to the insurance databases, to socio-demographic and economic databases that include health certificate data, data on taxable income, level of education, marital status, things like that, on the entire Belgian population. We believe similar data are also available in other countries, for example, as we already saw before, in the US in Medicare and Medicaid databases. However, these data cannot be used directly because they're not collected as a monitoring tool. That's why we need quality indicators, and we developed them, and we partly used already existing quality indicators from literature, but we also had expert interviews with medical and clinical experts for to develop additional quality indicators. We developed 3 sets of quality indicators. Of course, it's pathology specific. So one set for cancer, one set for people with COPD, and one set for people with Alzheimer's disease. All 3 of them people dying from these diseases. And the quality indicators that we developed treat 5 main themes: aggressiveness of care, pains and symptom treatment, palliative care, place of treatment and place of death, and coordination and continuity of care. I also brought you a few examples that we to show you in the article as well. So the top 2 quality indicators are specialist palliative care and official palliative care status. Those are indicators if they occur in a large number of the population that we could say that they indicate a level of appropriateness of care. The bottom 3 indicators are indicators that indicate a possible inappropriateness of care if they occur in a sufficiently high enough number. We did a quick comparison with numbers from the USA, but it's from research from Earl and his colleagues. They used the Medicare database to do the same thing for chemotherapy in the last 14 days. But of course, seeing these results, we can ask ourselves, what percentage is desirable for these quality indicators? How can we set standards or set norms or goals? And one major way to do this is to use comparison. We can compare across healthcare providers, or we can compare across countries, like we saw in the presentations before, to compare the effectiveness of healthcare systems as a whole. For example, we could set 25% benchmark as a standard. For example, if we measure indicators in several healthcare providers or in several countries, and then we set the best scoring 25% as a target, that would be for both realistic and ambitious, we believe. Of course, we have to take into account other aspects of care and other patient characteristics as well. So to make a fair comparison, you have to do some risk adjustment as well. That's why we have the socioeconomic and socio-demographic variables in there to make a fair comparison. Okay, that's about it. I think let me just summarize maybe the main points that we need to monitor public health that we need to monitor appropriateness of care on a public health level, on a population level. That administrative databases are a good tool to do so, but that we need quality indicators to really use these databases, and that we can set targets and goals and benchmarks if we compare healthcare providers, countries. Thank you for your attention.
Thank you so much again for allowing me to be here today. There is a delay. Oh, it's highlighting them. There we go. Okay. Okay. Thank you for allowing me to be here today to present work that truly took a massive team, and I'm here just representing them, honestly. So advanced directives have really been promoted as the primary tool over this past several decades for an individual to document their care wishes and allow physicians and clinicians to honor these preferences. Just to get a jump start on Alan, semantics are really important in advanced directives, and so for today I'm talking about sort of the common legal definition of advanced directives. That includes a healthcare power of attorney in which an individual can document a surrogate decision maker in the event they become seriously ill and unable to make their own decisions, and or a living will in which they document specific care preferences they may or may not want near the end of their life. And so prior work has shown that completing an advance directive may make individuals more likely to receive care consistent with their stated preferences, assuming stability, as Vince pointed out, may make them more likely to die at home, which seems to be the preferred outcome, and less likely to receive costly care near the end of life in certain regions. However, there have been several legal and educational national efforts to promote advance directive completion over many decades, such as the Patient Self-Determination Act and more recently Medicare's reimbursement for clinicians to discuss advanced care planning, which can include advance directive completion, yet we don't really know the outcome on a population level of these efforts. And so we sought to establish really a benchmark of sort of where we are on the spectrum. So my group reviewed the biomedical research evidence for the last 6 years for any study that published on the completion of advance directive rates among any population in the US, US adults. And that was 2011 to 2016, but I'll note the data goes up through 2015. And what we found is that overall, 1 in 3 American adults has completed any type of advance directive as I defined it before. This really isn't terribly different between powers of attorney or living will, although slightly higher for powers of attorney. Many times the advance directive type was not determined to be either one, and when we looked across the studies, you can see there's great variability in reported rates, which I think many researchers who use some of this data over time probably know. You could find rates of, actually one of these studies said 0% and one says 99%, but when you take all comers, you account for that variability, it's 1 in 3. We dug a little deeper into the data and looked and found that that 36.7% is that overall completion rate, as I said, that when you look among patients versus community dwelling healthy adults, it's slightly higher for patients, even slightly higher for older adults. And the highest rate of completion was among those already enrolled in hospice and or living in a nursing home. But I think what's important to note is even among the vulnerable population in the nursing home who are at higher risk for critical illness and or sudden death, still nearly half do not have any sort of advance directive completed. Again, we dug in a little further and looked just at patients and tried to identify, using just the study data that we had, what their primary disease type was and the completion rates across those disease types, and these were the only ones in which data was available for. And you can see that neurologic diseases, which is predominantly represented by dementia, had the highest rates of advance directive completion, whereas heart disease, cancer, and renal disease remained below the 50% mark, and HIV and AIDS had remained below 20%. I think notably what's not on this slide are other diseases. So as a pulmonologist, I know there was a dearth of data in chronic lung disease, and to Melissa's presentation, there was really nothing identifying patients with comorbidities. And finally, we looked across the years of the data published. This was highly correlated with the years of data collection, and we found no difference across the years. So really no trend up or down in terms of advance directive completion, despite ongoing efforts. I think in summary, our results sort of simplistically say advance directive completion rates are low and are not increasing. But I think more importantly, putting them back in the context of policy, we have a Patient Self-Determination Act still mandates Medicare subsidized institutions promote completion of advance directives, offer information, ask about these documents, and advanced care planning now being reimbursable as an activity which can and explicitly does include advance directive discussion and or completion. I think to take the bigger step back and say perhaps that we need to really dig into what the advance directive document is and if it really is serving our patient and family needs, which I think many would argue the content deserves much addressing, and the laborious process to complete one, which I won't bore you with today, but has many, many hurdles for sick patients to complete a true legal document of an advance directive. And I think a lot of work is and will be done in this context, and this study serves as a benchmark for where we're starting. Thank you.
Hi, I'm delighted to be here today. Josh Lakin, the first author of this paper, sends his regrets. I'm going to be talking about an intervention study to actually improve advanced care planning rates. And in order for you to understand the intervention, I'm going to tell you a story. I have a mentor, Atul Gawande. He's a surgeon, and an author, and he was writing an article several years ago about what we can do when we can't cure a patient. And when he was writing that article, he interviewed another mentor of mine, Susan Block. And in that conversation, he said something to the effect of, I don't have very good conversations with patients at end of life, and I'm not really sure why. And I think that's interesting in and of itself. And Susan said, well, what questions do you ask? And he told her, and she said, why don't you try these questions? And he jotted them down. And so with the next patient he saw, he sees many patients in the ER with cancer and emergency situations, he used a set of questions, and he had what I would call a transformative experience. He had a conversation that was like much more meaningful, talked about what really mattered to the patients, and was very different than what he had been taught to do, which was to talk about procedures and code status, and not really meaningful. So he was so moved by this that he said, we should train everyone to do this. We should train surgeons, we should train oncologists, we should train nephrologists, and so together we put together a program. So Dr. Block, who's an expert, and I and Dr. Gwande put together the Serious Illness Care Program, and I'm going to talk about the program first before I talk about the details of the study. The program has 3 parts. It has simple tools, education, and systems change. So the centerpiece tool of the program is the Serious Illness Conversation Guide, which is a set of 7 questions to discuss advanced care planning. It starts with, what is your understanding of your illness now? And then it asks patients, how much information do you want? And then it gives clinicians patient-tested language to convey prognosis. Following that, we ask patients, if your health gets worse, what are your most important goals? And then it allows clinicians to dig deeper into what's important to patients and ask questions like, if you were to become sicker, how much are you willing to go through for the possibility of more time? So, and then questions like, what abilities are so critical to your life that you can't imagine living without them? So the guide's been revised several times as we learn how it works in various populations. The training is intentionally really short. It's 2.5 hours to fit in with busy clinicians. And it really centers around giving clinicians practice, because these conversations are really hard. People have a lot of anxiety about them. They don't know what to say. And I've done probably hundreds of these trainings now at this point. And the key point is that they work with an actor, and they use the guide with a trained facilitator and learn how to use the questions in a patient-centered way. But we all know that tools and training really isn't enough. We need system change to incorporate so that every patient has a conversation about what's important to them early in their disease course before, so that they can have time to process this and make really good decisions. So the system change incorporates patient screening. So we use the surprise question. Would you be surprised if this patient died in the next year? Our primary care clinicians had trouble answering that question, so we changed the framework to 2 years, and it's still not a perfect screening tool, but we wanted to identify all the patients that needed conversations. Then we built in reminder systems. I call this the NAG, so that we would make sure that clinicians would have the conversations. And then the last key part of our program is that we built a documentation system within our electronic health record that embedded the questions in there. So we had one single source of truth where all clinicians knew to get this information. It's surprising, but you can spend up to 30, 45 minutes trying to find this conversation going through all different types of the medical record. And then we also have patient and family resources so that patients know how to talk with their families about this. Okay, so the objective of our study was really to determine the impact of this implementation of this program in primary care. So we worked in the Brigham and Women's Hospital in the Integrated Care Management Program, and we worked in 14 clinics. We used 6 as implementation clinics and 8 served as our comparison clinics. And this was a prospective implementation trial, and we did chart reviews of documentation of advanced care planning and looked at how often those conversations occurred, how accessible they are, could we find them in the medical record, what the timing of them was in relationship to death, and then how comprehensive were they? Did they have information about what people really mattered to patients? So these are our results. So we found that 100% of our nurses were able to participate in the training. Almost 80% of the physicians participated. And overall, the clinicians rated the training 4.7 out of 5 in terms of effectiveness. We saw that the frequency of conversations was higher in our intervention group, so 63% of patients who died had conversations recorded in their medical record, as opposed to 42% in the comparison groups. They were more accessible, so 44% in the intervention versus 3% in the comparison. The timing of conversations wasn't different between the two groups. They happened approximately 4 months prior to death, which is quite early in comparison to other trials that looked at this in cancer, where it's closer to a month prior to death. And then the comprehensiveness, so we looked at, did clinicians record what really mattered? And they, in the intervention group, there was a mean of 2.8 versus 1.8 components of things that were important, like I don't want to be a burden to my family, or it's really important to me that I'm mentally aware of those kinds of things. They took a reasonable amount of time, 26 minutes for the nurses and 22 minutes for the physicians. But the exciting thing, I think, is that we saw that this could really be a team sport. So 42% of the conversations happened and were documented by multiple members of the team, which I think reflects that these conversations are really difficult. And this is really sharing the benefits and the burdens of having these conversations. So you can see the physicians did them 37% of the time alone and 19% for the nurses. We also looked at hospice utilization, which wasn't statistically significant between the groups because the numbers were small, but 55% in the intervention group used hospice versus 40% in the comparison groups, and the length of stay was longer, 51 days versus 29 days, but again, because of our small numbers, we were limited. So in summary, our program was really viewed as effective by clinicians and feasible. They were able to incorporate this into their busy work days. And what we saw is that we had more conversations. They had more information about what really truly mattered to the patient, and they were easier to find. But it highlights several significant needs. We need a better way to systematically identify patients who have serious illness. The surprise question in other studies has been shown to miss almost 80% of patients who are at risk. So we need better ways to do this, and machine learning and those kinds of things are available, but not readily able to be implemented. We also really would have liked to have collected the information about how patients responded to this intervention. However, it wasn't in the scope of our study, and we need better routine measurement about things that are important to patients. We also need increased training and coaching for clinicians to conduct these conversations. There's really a lot of anxiety, and having a structure can really reduce that anxiety and allow them to have these conversations more. And then last, we need some data on the cost implications of the interventions. I think the Hospice Palliative Care, or the Palliative Care Training and Education Act could fund many of these efforts. Thank you.
Now we went 3. Thank you. Okay. Well, thank you. I'm Judy Lucas, presenting today on, this is an evaluative study of CMS strategies that were used in 2012 to 2015 to improve dementia care and to reduce antipsychotic use in nursing homes for patients with dementia. The background to this really involves the overuse of antipsychotic medications in this population. Antipsychotics such as haloperidol, Haldol, Zyprexa, olanzapine, and many others are overused in order to control behavioral symptoms in nursing home patients with dementia. We don't have a medication that is approved for behavioral issues, and therefore it has become very routine to use these medications. We also know that these medications lead to adverse effects and increased mortality risk for this population group, particularly patients with dementia. And there have been FDA warnings, and even though there have been warnings up through 2008 for all antipsychotic use in patients with dementia, they have continued to be used. So in 2012, the Centers for Medicare and Medicaid Services initiated 3 strategies to improve dementia care and to reduce the use of antipsychotics. The first was the national partnership itself. This was a public-private partnership to improve dementia care and to reduce antipsychotic use in particular. Then they implemented public reporting of 2 measures that were developed to measure the use of antipsychotics in nursing home population. This was published on Nursing Home Compare, so that consumers could then have information and choose specifically. It was interesting. I noted some of the comments, because even though we say we give consumers a choice, there really isn't sometimes in these situations. They also revised federal nursing home survey guidelines for state surveyors. Now, for those of you that are not familiar, the feds set the guidelines for care. The states evaluate, inspect, and write up deficiencies for nursing homes in order to improve care. So they spent time revising the guidelines around dementia care standards, and that was around the deficiency F309, or the quality of care measure. And they also spend time identifying very specific guidelines, training, and even giving specific examples on unnecessary use of medications, particularly antipsychotic drug use. Is this going to move? Oh, now we went 3 again. I wait and wait. Okay. The purpose of our study then was to determine if, with these strategies, were there changes in the number of deficiencies that were being issued and the prevalence of antipsychotic use. And were these associated with each of the CMS strategies? We also had a secondary objective, and that was because we know that psychoactive medications can be substituted for antipsychotics themselves, and they might be used in order to comply with these new CMS efforts. So we wanted to examine the prevalence of other antipsychotic medications. I'm giving up on moving. So we looked at anxiolytics or anti-anxiety medications, sedative hypnotics, antidepressants, and then any psychoactive medication that might be prescribed in the data that we had. Our data, we utilized CASPR data, which is partly self-report, partly visitor verified, and includes resident characteristics, institutional characteristics, and medication use. And this is collected annually at the certification survey. So we really examined the surveys, the nursing home surveys across all nursing homes in the US from 2009 to 2015. And this was a total of 86,000 above surveys and 15,000 unique nursing homes. We examined the trends in the population of surveys, the proportion of surveys, that targeted the deficiencies that we were interested in, F309, which is quality of care, and F329, which is unnecessary medication use, and the prevalence of antipsychotic and other psychoactive medication use. We tested our responses to see if they were associated with each strategy, and we used regressions, which I will not use today for you. And I will avoid that for you. We examined the extent as well and the responses to CMS strategies and how they differed among the states. And these are our trending results, and I can see here that they aren't going to be well seen on this, but the dotted lines indicate these citations that we're talking about. We were interested to see if the citations were going up after there had been all of these changes. And as you can see with the lines demarcating, and I'm sorry we don't have a laser to point with, that after the national partnership, the The citations actually stayed about the same for 309, which is the dotted line. It's a red dotted line. And they actually didn't change throughout the entire study period. So we really don't have a lot to say for dementia care standards changing and whether or not we saw any more scrutiny of dementia care following any of the strategies. The blue dotted line that's below that also was fairly consistent prior to the to the partnership, and then it went up dramatically, about 5% of increase in citations for antipsychotic use. So overall, finally, our results tell us a few things. It tells us for deficiencies, unnecessary drug use, those deficiencies increased after public reporting and the guideline revisions, with a larger increase we found in high antipsychotic use states, which I didn't give you a lot of numbers for, but we saw that happening throughout. For antipsychotics themselves, we saw a decrease, and these were associated with each strategy. In the end, we saw in our data 10%, which is comparable to what CMS reported, which at the same time about 18%. We had different measures for ours. We were measuring them against all nursing home population. They were looking at only long stay nursing home population. We saw the greatest decline among the high-use states. For anxiolytics and sedative hypnotics, we were very surprised. We assumed, and we have seen following public reporting, that anxiolytics went up, but we did not see this substitution in this data. We did see reductions with each of the strategies. Antidepressants and all psychoactive medications, and I didn't point that out in the last slide because I saw my time disappearing. But what we saw was a decrease after the partnership initiation, a leveling off for antidepressants and all psychoactive medications with public reporting, and these are not publicly reported, so that's important. But they increased after the guideline revisions. We feel that nursing homes were relieved that they only had to focus on one type of medication, and we also had recommendations and some data from the citalopram studies, trials that indicated that certain antidepressants might be useful for agitation in patients with dementia. So you'd expect to see this increase. Our results also, we did look, and I'm not presenting them today, but we also looked at different the nursing homes, whether the well-financed nursing homes or whether nursing homes that had very high percentages of dementia patients reacted differently, and they basically reacted about the same, except we saw a decrease in antipsychotics of 12% for those that were high in dementia, with dementia patients. So for conclusions, maybe. I don't know why, I pressed forward and I got backwards. Here, I'm going to give it to you. Find that for me. CMS strategies are starting to work. They are having the intended effect on reducing use of antipsychotics. We really only saw the change in the antipsychotic use, not in dementia care, and perhaps that's because they had just started to improve their standards. We saw what we consider a modest reduction, and even a modest reduction can help patients with dementia, because patients that are treated with these meds fall, have fractures, have very painful end of life. They die unexpectedly with cardiac conditions and strokes, and they are sedated and have a miserable quality of life, even worse than they were already experiencing. States' responses varied. I think that's always the issue here in the U.S. The effect was larger, of course, as to be expected, in the states that had high use to begin with, because they knew they were being targeted. States did show buy-in, at least the surveyors showed buy-in, because they were now targeting at least one deficiency. But we did not see differences in what's called scope and severity ratings of the citations. And that's very disappointing, because if you're not given a really strong citation with a high level of severity rating, there is no penalty. So we are giving a mixed message. Antidepressants and all psychoactive drug use rebounded in our data, as we indicated in the trends, and also we saw that in our regressions. We need to monitor these. There is always going to be the potential to replace antipsychotics with other psychoactive medications that have similar sedating effects. So besides drug substitution, I would also suggest that we need to look at the overall drug burden that our patients with dementia are given, because we do know, and that's not our research, but other studies from University of Maryland, for example, have found that dementia patients are given 2 to 3 psychoactive medications during their nursing home stay. So we would ask for continuous monitoring, or we're going to lose the progress we've made so far, training and consistent enforcement with the penalties. These will be needed to continue the unnecessary use of antipsychotics and the burden of psychoactive medications for these patients. Thank you for giving me that. I'm sorry, I don't know what's going on.
I want to ask one question, pull out the lens a little bit. This was a tremendous collection of in-depth examinations of different aspects of quality of care and working with patients. But Joan, as you started us off in the move to value, this whole question of accountability, we're in the midst of a national move to try to embrace quality measurement in healthcare. I would ask each of you to pull away from the specific work and reflect on where we are in the process, in our progress of coming up with a useful set of measures that we can collect appropriately, affordably. How much can we rely on administrative data, the survey data, other interventions? Just put these very detailed examinations of specific elements of quality into the context of where we are. I'd be interested in your reflections on that.
So we're at grade school, and we have a lot of progress to make. And I think one of the things is we have to look at quality measurement as just one part of a set of interventions that need to be done. So, when you, for example, just think about disruptive behavior, if you don't train your staff on how to care for these people, if you don't have the adequate financing so that you have enough staff. So we really need to start really embracing the complexity of multifaceted interventions that are needed. Quality is one part of the solution, but it's not the entire solution.
Robert?
I would like to add to that I think that the most effective level of trying to change something is most of the time the population level, the healthcare system level. So if we can do something about on that level by comparing healthcare providers, for example, that would be a very useful tool to complement specific actions in practice.
Good.
So I agree with Joan. I think we're very nascent, but to me it's very exciting because we're all thinking about it. And I think one of the universal truths is we all want to provide care that is consistent with what patients and families want. And that embraces the heterogeneity and complexity we talk about. But how to then sort of drill down and measure that has just, to me, been mind-boggling, somewhat overwhelming, and I do not have the answer. I also think that's why there's been so much of a focus for decades on documentation and sort of standardizing that, because that was something we could sort of check the box and say advanced directive done. But as both I feel and many others, that it sort of brings it down to a level that it maybe no longer is as meaningful and isn't capturing exactly what advanced care planning is and documenting those preferences in a meaningful way. So I'm open to ideas.
Two thoughts about that. We looked at documentation of advanced care planning. It was incredibly complex to do a chart review to look at what's actually meaningful, and there's no accepted standard on how to do that, really. The other thing that's difficult, and I think what Joan was talking about, is we have a complex system and we need complex interventions to then solve those complex problems. But it's hard to then pick out the pieces that really matter. You know, our program has patient identification, training, documentation, training, electronic medical records, and we don't know which pieces of it make the most difference, and that makes it difficult to know how to tell other systems to implement our program.
I'll take two sides to the question that you asked. The first is the patient side. I think one of the things we don't find out in our quality measures is what is important to the patient or their family. And in some cases, for example, in dementia care, our system is set up that actually families hide that they have a patient that has dementia because they might not be acceptable, especially because of disruptive behaviors in certain better nursing homes. I'll leave that to be as vague as it can be. The second thing is we do not pay for long-term care well enough so that it can be done well. It is always an afterthought. We minimize it. Many patients have to spend down, and they're spending down in assisted living settings, which have long called themselves anything but dementia care settings because there are standards for dementia care, voluntary standards for dementia care. And for many years, the Alzheimer's Association has been arguing we need federal standards for dementia care. So we're just at the baby steps of dementia care. And that's a quality of life issue, and that's why it's extremely difficult to measure, because it is a quality of life issue. But that doesn't mean we shouldn't try. I would argue that even measuring for appropriate use of drugs is very difficult to do, and we've all been there. So I would say that we have to look at it from both perspectives. This is not my particular favorite use data source. For this kind of information, I tend to use the MDS, which is patient data, clinical data, much better data. But this is available, and it does give us information to guide us, to let us know if policy are having any effect at all. So from an evaluative point of view, it's useful.
In the back. Come over here.
Hi, my name is Dr. Doberman, Daniel Doberman. I'm a fellow palliative care clinician. I wanted to thank the panel and ask Dr. Bernacki a question. You had some time flow data in your study, and I think that's very important in the palliative work, especially when we're talking about reimbursement and quality. And you also talked about nurses as well as various palliative providers performing the work. With the new advanced care planning reimbursement, it is outlined by Medicare very specific providers who can perform that for the reimbursement. So I just wondered if you could talk more about the time flow and also maybe some other studies that you might know that talk about that.
We implemented this program in an integrated care management program where nurses were care coordinators for high-risk patients, and they really drove this program. They really took on the responsibility and were sort of, in some ways, the nags to get the doctors to have conversations. And they really, because they were seeing these patients go in and out of the hospital and through the churn that we heard in the first panel, I think they were really motivated to have these discussions about what mattered and get them onto a path that perhaps was more congruent with what their wishes were. And so I think in many ways they were empowered through the program to provide the kind of care that they wanted to. And I think that sometimes we overlook how important nurses are to doing this kind of work. Your second question was about the time flow. We hypothesized that we wanted these conversations. Often, as a palliative care clinician, I often feel like I come in at the very end in the hospital setting when there's really not enough time to have good decisions and really process information. And so this was really appealing to me to try to intervene at an earlier time point where there could be more meaningful discussions and more time to actually fulfill patients' wishes. We didn't see any changes, though, in this study. In primary care, I think, these conversations happened on average 4 months before death, which is not too bad. But however, we are doing other work in oncology, and we did see a really significant difference. That study is under review, though, so I can't talk in specifics about it. So thank you.
Question up here. We can go to the back, and then we'll take you, and then we'll be out of time. So. She's right behind you.
Hi, my name is Patty Webster. I'm with the Conversation Project and the Institute for Healthcare Improvement, and I just want to thank all of you. This has been a phenomenal discussion about patient involvement, and I think for this panel, this is kind of an open question, and we've heard it in the other panels, the importance of hearing from patient and family members why, what really matters to you, and you all were very thoughtful in pointing out what are the next questions for the next set of research. How have you been able to, or what are your suggestions for including patient and caregivers in the research process itself, designing studies and making sure we're asking the right questions in that process, as well as following up and what really matters to them?
I'll start us off here. I've been very fortunate to work with the CAPS team, and always at the beginning of every time that we work on a measurement development process is extensive focus groups to speak with consumers and to speak with not only dying persons or the target population, but also speak with families about what their experience are. And I found that, in my own work, that's been invaluable. The one thing is, I'll note that over the 20 years I've been doing focus groups, the same recurrent theme comes up time and time again. Family members feel that they have to advocate and they have to be vigilant advocates in a healthcare system that's not responsive to their needs. They feel like they're being shuffled through the system without anybody to really provide a coherent episode of care, that they have to somehow piece it together. If anything, people have told us in focus groups that they'd rather be on a chemotherapy trial because at least someone's helping coordinate their care.
One more.
From our work, I know many of my colleagues at Penn and honestly around the country are working to involve patients and families in the sort of redevelopment of the content of advanced care planning documentation, whether you call it an advanced directive or something else, sort of what, instead of making it so clinician focused, as I think the original Living Will and Healthcare Power of Attorney really did, what do patients, families want and need to see at the time when they're there speaking and advocating for their loved ones in terms of prior conversations and what's been elicited? How do they want that documented? How do they want that to be? And how will it be most helpful to serve them to make those future decisions? And sort of marry that with how clinicians need to then enact those decisions. But I think they need to be involved in the development process.
Take a last question back here.
Ian Kramer from the LEAD Coalition. Thanks again to the entire panel. Dr. Courtwright, in particular, in terms of advanced directives, rates of completing those are terrific, but it's adherence and compliance by providers that really is the difference for families and for patients. So I wonder if you've looked at that data at all across at least 3 domains or others you might care to mention. The ones I'm interested in are gender, setting of care, and cognitive status of the person with the advanced directive.
Gender. So we were unable to look at gender. Well, I'll just say actually for our review specifically in the data I reviewed, we were unable to look at adherence. So this is simply completion. I think that well described is that completion of advanced directives, whether you think it's high, low, or just right, doesn't get at accessibility. And to your point, most of the time that's the bigger issue, and that gets to the laborious process of completing them and then how to disseminate that information. I've personally I'm not aware of data regarding that difference gender-wise. Place of care, I would imagine that electronic health records hopefully are sort of changing the landscape of accessibility perhaps, such that you might, from an integrated standpoint, if we ever get there, might be able, so for example, the VA system, you can have an advanced directive completed in the VA system anywhere, and it's accessible if you're dying in a hospital in a different state. The rest of the country isn't there yet, but I think that would be an ideal. And then I forget your third group, please.
Setting of care, so whether say, faith-based hospitals are more or less compliant with end-of-life wishes.
I don't know. I don't know the answer to that question, honestly. Perhaps somebody else does, and I don't know that anyone's looked at it in that direct regard.
Oh.
One thing I'll really mention quickly is one of the wonderful mentees I work with has an article in the Journal of Palliative Medicine that just came online using National Health and Aging Trend Study, and asked brief family members how often they thought their patients' wishes were not followed. It was around 11%. And I think in that article, she did break it down by whether someone died in ICU, how often it was not consistent with their wishes. So that might be a source of information for you.
Well, please join me in thanking our panel. We know we've been going for a while, but we have a terrific final panel here. If I could get them to come up, we'll keep going and get you out of here as scheduled. But as a number of the speakers have noted, there's a flow and evolution to the discussion, and the themes will recur as we finish up here. So in our final panel, which is going to focus on hospice care and palliative care, we'll be hearing from Diane Meyer, Director of the Center to Advance Palliative Care, which is a national organization devoted to increasing the number and quality of palliative care programs in the United States. We'll hear from Susan Miller, Professor of Health Services Practice and Policy at the Center for Gerontology and Healthcare Research at the Brown University School of Public Health. Rebecca Anhang Price, a Senior Policy Researcher and Associate Director of the Health Services Delivery System Program at Rand Health. Rachel Dolan, David Winston Health Policy Fellow here in Washington, D.C., and a National Science Foundation Graduate Research Fellow. And Dina Keller-Moss, a Senior Program Analyst and Action 3 Lead at the Agency for Healthcare Research and Quality, who will be presenting her Narrative Matters piece. So I'll turn it over first to Diane.
Thanks, Alan. I want to congratulate you and your editorial colleagues at Health Affairs on a really superb issue. And what I want to take this to a level of, so what? So we have a lot of data here. We are really good at understanding the problem, not so good at doing anything about it. So with my co-authors here, we spent a lot of time thinking about what could actually practically be done. I'm going to begin by defining palliative care because of a question asked earlier. If you Google that question, what is palliative care, this is what comes up. Medical care for people with serious illness focused on providing relief from symptoms and stress. The goal is to improve quality of life for the patient and the family. Says nothing about prognosis, says nothing about having to give one form of care up to get another form of care. It's an added layer of support to make the added years worth having. And the definition of palliative care, as Alan pointed out, is increasingly being understood as a concurrent care model, not as an either-or care model. The either-or model is enshrined in the Medicare hospice benefit and unfortunately has spilled over to confuse people about palliative care. So this is where we're trying to get to as a nation, and you'll see that when disease-directed therapies end, the dark blue, that is the point at which, under policy, current policy, it becomes appropriate to refer patients to hospice, the highest level, most intensive level of palliative care for people who are dying. I'm not going to review the data on the impact of palliative care on value. This is obviously critical for moving from volume to value. Palliative care is something that does both, improves the numerator, decreases the denominator. It is by improving quality and epiphenomenon of better quality that we see lower cost. If people don't have pain crises that lead them to 911 calls at 3 in the morning, their costs go down. They don't have pain crises because somebody told them what to do when the next pain crisis occurs so they can manage it at home. It's as simple as that. But what is the denominator population for what we're talking about? Is everybody in the world need palliative care? Is it people with a cold? Do they need palliative care? No. So in attempting to define the denominator for whom we want access to this kind of care, you can either use disease type, so you can use the Dartmouth Atlas criteria for a serious illness, those are listed here, or you can use the impact of the illness or illnesses on the patient and the family. So Amy Kelly's done the most work on this, and this is a quote from her paper. Serious illness is a health condition that carries a high risk of mortality and negatively impacts a person's daily function or quality of life or excessively burdens their family caregivers. So if you think about it that way, and then you look at the costliest 5% of patients, and the reason I focus on this group is, obviously we need to think about how to moderate spending in this country, but cost and spending is a marker of need, right? So if you're looking at the highest need group, look at the high spending group. And what most people do not know, but was concurrent with data that was presented earlier in these panels, is that although everyone thinks that the costliest 5% are all dying, in fact, only 11% of the costliest 5% are in the last 12 months of life. Not 6 months, but 12 months. Fully half of the costliest 5% have one-time high costs, like a total hip replacement or bilateral total knee or CABG or transaortic valve replacement. Very costly episode, but it helps. And the person's spending regresses back down to the average in the following year. That's not a group that needs continuum of palliative care over years. But the remaining 40%, and this is the group that Joan was referring to in her comments, is the people with multiple chronic conditions and functional impairment who are not dying, but living for many years with dementia and other comorbidities and very high family caregiver burden. So it's the green and the blue that needs long-term attention in community settings. And when you think about where palliative care is accessible, it's highly accessible if you're dying in terms of structure. There's hospices out there. We don't use it as appropriately as we could, but it's there, it's built, and it's paid for. And hospital palliative care we now have hospital palliative care in 94% of the larger hospitals in the US that serve most people with serious illness. The gap is in the middle. And it's in community settings, home, nursing home, assisted living, office practice. And why is that important? Because most people who need palliative care are not dying, and most people who need palliative care are not in the hospital. So it's a chasm. And that is where we need policy attention to fill that gap. And this is actually in the appendix of our paper. We didn't get to put it in the paper itself, and it's a logic map that was modified from Tom Valek's Health Affairs blog of a few months ago that basically takes the analogy that Health and Human Services, there's quite a strong history of public-private partnerships, and they are listed in our paper. The National Alzheimer's Program, the attempt to reduce central line-associated bloodstream infections, all of these things were done through a combined effort of multiple private sector entities and a cross-government working group. So we propose that HHS takes that on with private sector support and participation, developing a range of multi-lever strategies that will drive both payment and delivery changes that are accountable, as Joan was saying, for quality and cost, and that would result in reaching seriously ill people in the community with consistent, reliable, accessible palliative care. Thank you.
Well, good morning. It's still morning by a couple of minutes. I'm happy to be here today to share our results on increasing veterans' access to hospice care. I want to acknowledge my collaborators who are listed here on this first overhead or slide. And I want to acknowledge Orna Entrato, who's in the audience, who's the director of the Geriatric and Extended Care Data Analysis Center, who is key to this study. Although I led the paper and the evaluation, it's the efforts of the people in the VA and the leaders who are listed here, Tom Eads, Scott Shreve, and Richard Allman, that really brought about this change. Okay, no, one back. All right, the VA recognized that there was a need to improve its end-of-life care. In 2000, it was projected that the older veterans, those 85 plus, would grow increase, the numbers will increase threefold compared to twofold for the US population. Also, only 5% of veterans who died in 2000 accessed hospice, but 20% of Medicare beneficiaries accessed hospice, 15 percentage points greater than those veterans. So the VA embarked on quality improvement efforts. In 2002, it began the Hospice and Palliative Care Program with the mission to honor veterans' preferences for care at the end of life. The VA was in an enviable position because it's an integrated healthcare system, actually the largest integrated healthcare system in the US. So it controls its payments, its policies, and it employs its clinicians. So the VA approached this effort by addressing policies that were needed, developing programs, developing staff, and coordinating with community providers who provide most of the hospice care to U.S. veterans. There were a lot of improvements seen in this initiative. There are two policy components of this initiative that I want to emphasize. One is that the VA required or mandated that veterans have access to concurrent care, that they're allowed to receive hospice as well as disease-modifying treatments at the same time. This is not available in the Medicare hospice benefit currently. Also, the VA in 2002, as part of this program, mandated that every VA medical center have a palliative care team. And this was the first system of care that did this. So lots of improvements we're seeing, quality improvements, increased access to hospice, but there was concern that there weren't enough resources for the veterans to meet their preferences. So in fiscal year 2009, they began a 4-year comprehensive end-of-life care initiative to increase these resources. At that time, the VA funded palliative care staff to provide palliative care consults in all VA medical centers. It also funded 54 new inpatient hospice and palliative care units in VA hospitals. And our goal in this study was to evaluate the outcome of this initiative. One outcome, hospice use. There are a lot of other outcomes also, but this one was of particular concern. So we knew in the same time period that the US population began to use hospice a lot more. And so we wanted to differentiate the difference in growth for veterans versus Medicare beneficiaries. So we did a difference in difference analysis where we looked at the difference in hospice use between the post years and the pre-years. And we compared those differences to our reference group were Medicare beneficiaries who were not VA enrolled decedents. And we compared to that reference group veterans groups of veterans who enrolled in the VA health system and used different types of care. So some veterans used only the VA health care, either purchased or provided. Some veterans used Medicare and the VA, and some veterans only used Medicare. We found there was a difference. We found that the increase in hospice use for veterans surpassed the increase that we saw for Medicare beneficiaries who were not enrolled veterans, and the relative percentage of increase was bigger for all the veterans group, and the next slide shows this. So in this slide, we see that the relative percentage of increase in hospice use was higher for all the veterans groups. The veterans groups are the top 4 bars here, and you can see the increase is higher than the last group of Medicare beneficiaries who weren't veterans. The top 2 bars are veterans who used only VA purchased or provided care, and they had the biggest relative increase in hospice use. On the next slide, we show the absolute difference in rates of hospice use increase. On the left-hand side, we looked at the entire population, and the veterans groups on average had about 2% greater increase in their rates of hospice use, and these are absolute percentage point. And all of this analysis is adjusted using multivariate analysis. What we were really, in our sensitivity analysis, we were interested in what happens when these veterans actually accessed the VA Medical Center where most of this intervention and investment occurred. So on the right-hand side, we included only decedents, both veterans and non-veterans, who had used an inpatient, had an inpatient hospitalization in their last year of life. And you can see when we did that the two VA-only user groups had doubled the difference. Now each of these groups had an increase in hospice of 4 absolute percentage points more than we saw for Medicare beneficiaries who used the inpatient setting. So our conclusion is that this effort, this Salk initiative, was effective. And if we look back to 2000, there was a 15-point deficit in the veterans' use of hospice. And now, in 2014, for these at least 2 groups of veterans, we see a 4% increase, or they surpassed the use of hospice by 4 percentage points. So this is we feel a big increase, and the program, we feel, can be credited for this. Thank you.
Thank you to everyone for the opportunity to be here today to share research on behalf of my team at RAND, as well as my team member from the University of Washington, who you've heard from already today. So as Dr. Aldridge and Dr. Miller mentioned already today, hospice use has grown substantially over the past number of years. And this has been true across all racial and ethnic groups in the United States. However, Black and Hispanic patients are still much less likely to enroll in hospice. And once enrolled, Black and Hispanic patients are less likely to receive recommended care. A couple of examples of this are that they're less likely to be visited by skilled professional staff members in the last couple of days of their lives, and they're more likely to be discharged alive. But what's less well understood is the degree to which those differences in the care they receive result in differences in the degree to which those groups find their care to be respectful of and responsive to their needs and preferences. That is, the degree to which the care is patient and family-centered. And the way we find out whether care is patient and family-centered is by asking patients and families. In 2015, CMS required most hospices nationwide to administer the Consumer Assessment of Healthcare Providers and Systems, or CAHPS, hospice survey to bereaved family members, the informal caregivers of patients who died while receiving hospice care a couple of months prior. And so what we do in this paper is ask the question, do hospice care experiences differ by patient's race and ethnicity? And we use data from the CAHPS hospice survey from approximately 2,500 hospices nationwide, based on respondents, almost 300,000 respondents, again, the informal family caregivers of patients who received care, from April 2015 through March of 2016. And specifically, we ask, to what degree are any of the observed differences we find due to racial and ethnic minorities concentration in particular hospices, or to differences in care delivered to racial and ethnic subgroups within a given hospice? And the CAHPS hospice survey allows us to look at a variety of dimensions of care that we know from work with patients and families are most important to them when they're receiving hospice care. That is, how well the hospice team communicated with them, the timeliness and responsiveness of care, whether the patient was treated with respect, emotional and spiritual support, symptom management, whether family members who are caring for a patient or family member at home received the training they needed to do that well, and also their willingness to recommend that hospice to others. And we found, with regard to the first question, that is, are Black and Hispanic patients concentrated in certain kinds of hospices, that on average, these patients receive care from hospices that provide worse care experiences. In fact, across all 7 measures that we were looking at from the CAHPS hospice survey covering the dimensions I just mentioned, the care experiences in hospices that Black and Hispanic patients attend on average were worse. That said, within a given hospice, caregivers of Black and Hispanic patients reported care similar or better to white patients on most dimensions, on 5 out of 7 dimensions, with the exceptions, notable exceptions of emotional and religious support and willingness to recommend the hospice. So this results in an overall finding across the country of a combination of the first result I described, so being concentrated in generally hospices that provide worse care experiences and reporting better or similar experiences within the same hospice, to an overall finding that differentially better reports within hospices compensate for the tendency of Black and Hispanic patients to receive care from poor quality hospices. And so our overall finding is that caregivers of Black and Hispanic patients report similar or better experiences than caregivers of white patients on most dimensions. But of course, it's very important to dive in to the two pieces that pull together into that overall finding, because if we didn't dig into those, we might mask the fact that on average, Black and Hispanic patients go to hospices that provide worse care experiences. And to show this more dramatically, we looked at care experiences within hospices by the proportion of Black or Hispanic patients within them. And this graph shows this for Black patients, but it looks almost identical for Hispanic patients. And what you see is that as the proportion of Black or Hispanic patients increases within a given hospice, reported care experiences are worse on every single measure that we look at. And this is true for white patients, for Black patients, and for Hispanic patients within those hospices, meaning these are hospices that provide worse care experiences as the proportion of racial and ethnic minorities increases. This is somewhat less true for Hispanic patients than it is for Black or white patients, and we think that that might be because as the proportion of Hispanic patients increases within a given hospice, there are more Spanish speaking services or perhaps culturally appropriate services for those patients. So what are the policy implications of what we find? The first is, as I think is clear from the graph I just showed, is that improving the overall care experience in hospices that serve higher proportions of Black and Hispanic patients stands to improve the overall quality of care for those populations substantially. And we could imagine that this could happen in a number of different ways. These hospices could target themselves for quality improvement. Alternatively, they could be subject to additional monitoring by federal agencies, looking in particular at what CAPS hospice survey results tell us about what could possibly be improved with regard to processes of care. The second piece is to ensure that subpopulations that currently are receiving lower quality of care are aware of the availability of better quality hospices. And one way to do this that CMS is pursuing over time is public reporting of quality performance information for hospices. So as many of you know, CMS is planning to launch a Hospice Compare website this summer with clinical quality measure information, with CAPS hospice survey measures to follow in winter of 2018. What we couldn't assess very well, unfortunately, in the data we had was the degree to which the Black and Hispanic patients we were following here had access to better quality hospices in the area in which they live, but that is clearly an important area for further work. Finally, since we found that emotional and religious support of Black and Hispanic patients was worse even within the same hospices as white patients, we note that this is an important area for quality improvement intervention and to link potentially the hospice to community faith-based organizations that can help to provide culturally appropriate care for those groups. So thank you very much.
Hi, everyone. It's a pleasure to be here let's see if I can get this to work. Wrong way. Great. Hi, everyone. It's a pleasure to be here to talk about the research I conducted with colleagues at the University of North Carolina, Chapel Hill, and also Duke University on the relationship between profit margins at hospices and their rates of live discharge. So as some of my colleagues have already stated, the hospice industry over the last 15 or so years has experienced a significant period of change. During that time, the number of hospices operating nationwide has increased by about 65%, and the number of 65 and older Medicare decedents accessing the benefit has also increased by about 30 percentage points. During that same period, the proportion of patients experiencing a live discharge from hospice has also increased pretty steadily. So when I'm talking about live discharges, I'm referring to patients that enroll in hospice and then leave sometime before they die for various reasons. This particular outcome has actually come under federal scrutiny over the last few years because of its association with various hospice and market level characteristics. So live discharges as an outcome are very interesting to study. They can occur for a variety of reasons, some of them patient-initiated and some of them also provider-initiated. And they can also be evidence of both good and bad quality. So we wouldn't expect the rate of live discharge to be 0% because we want some ability for patients to enter hospice and then change their mind for whatever reason. So you could also imagine a situation where a patient enters hospice, gets excellent care, stabilizes, and actually has more than 6 months left to live. And so under CMS regulatory guidelines, that patient must be then discharged from hospice. On the other hand, we can be concerned about live discharges that occur for reasons to maximize hospice profits. For example, a patient that's particularly costly might be discharged from hospice because of financial reasons. Oops. As I mentioned earlier, MedPAC and both CMS have expressed concern about this rising trend in live discharge rates over the last few years. So in light of all that, our objective was to explore the relationship between hospice profit margins and rates of live discharge under the hypothesis that potentially as hospices with higher financial margins also had higher rates of live discharge. Quickly on methods, we used Medicare claims and hospice cost reports. I want to emphasize we only used freestanding hospices for this analysis, so not hospices co-located within a hospital, nursing home, or home health agency. The reason for that is actually, in 2013 and 2012, the year of the data, freestanding hospices represented 72% of hospices nationwide. They tend to have higher profit margins due to their lower indirect costs. We conducted regression analyses. Our key outcome was the rate of live discharge in 2012 and 2013 at a given hospice. So the number of live discharges divided by the total number of discharges. So that's patients that both were discharged alive and discharged dead, or, well, patients who died in hospice. Our explanatory variables, we looked at both total margins and also operating margins. Really struggling with this. Oops. Sorry, guys. Which should I be pointing? There we go. Okay, results. Our sample included 1,439 distinct freestanding hospices. The live discharge rate, we found an average of a little over 13%. Total margin was a little over 12%, and operating margin a little under 7% for these hospices. I've included some basic descriptive statistics at the bottom of the slide there. They look sort of like you would expect if you've done research in this area. Overwhelmingly white patients, a number of more than half were for-profit, and many were operating in urban areas. So overall, the big takeaway was that adjusted analyses showed a positive and statistically significant relationship between profit margins and rates of live discharge, holding constant a number of hospice-level characteristics. This was true for both total margins and operating margins. Oops. And so in terms of implications, I think this was, to our knowledge, the first study that actually linked profit margins, profitability, and rates of live discharge. And so it provides some evidence to potentially corroborate the concerns expressed by federal regulators over the last few years. I would encourage future researchers to look at these changes in light of the payment system change that went into effect on January 1st, 2016, which created a U-shaped payment curve, so reimbursing higher rates at the beginning and end of stays. This might influence the relationship between these two factors. Unfortunately, data were not available during that time period for us to use, but there's always more research to be done.
Well, I'm really thrilled to be here to share this, to share my personal reflections on what was involved in ensuring that my mother's end-of-life wishes were honored through effective home-based palliative care. And I just want to emphasize that my comments are my own, even though I work for the Agency for Healthcare Research and Quality. Nothing here reflects anything that the agency or the federal government necessarily believes. So this is my mom, Florence Keller. She lived an active life filled with family, the arts, books, book groups, travel, and a really wide circle of very fun and very interesting friends. My mother had always been very clear to me about her wishes and anxieties with regard to the end of her life. And especially in her later years, as she watched those around her age, she would often remind me, very often, of her preference for quality of life over longevity, and in particular about her fear of living too long, which in her case meant living past the point when she felt good about being alive. So when she was diagnosed at age 89 with a colorectal mass in a hospital, she was there for 6 days, and every doctor that came by, and there were several each day, I don't ever remember seeing the same one twice, and I'm not kidding, she would tell them, I'm okay with this, no chemo, no radiation, nothing life-prolonging. She just wanted symptom relief while she lived out her remaining days as actively as possible. Let's see here. Oh, nope. So I foolishly thought that with her clearly stated wishes and with me as her committed advocate to ensuring that those wishes were honored, that we had the necessary ingredients for making this happen. And this just turned out not to be the case, at least in our experience. And in fact, I really almost blew it. Things started out well enough. As I mentioned, she mentioned her wishes to the doctors, and for the most part, they accepted them. Every now and then, they would sort of look at me questioning, you know, does she really know what she's talking about? And I'd said, yes, she's very clear about what she wants. They'd move on. But the near miss occurred when a surgeon asserted that the only way that my mother was going to avoid an excruciating death was with a surgery. And it was going to result in a colostomy, but that wasn't going to be too big a problem. And he said, she's just a great candidate for it. She should do fine. It's a minor of the several surgeries that were available, and so recovery should be easy. And he spoke with such certainty and authority that I assumed he must have been speaking from some knowledge that I lacked about the limitations of palliative care in my mother's specific condition. And so even though this flew in the face of everything we had discussed, everything my mother had hoped for, I advised her, Mom, I guess we have to go ahead and schedule a pre-op. And she actually cried. It was the only time she cried. But she didn't argue with me. I mean, she had heard this really chilling description of what lay ahead for her. Fortunately, I reached out to do a gut check with a colleague and a close friend, and she reminded me of what, in the emotion of the moment, I had forgotten, which was the third ingredient for our eventual success, which is the importance of probing assumptions and generalities. The surgeon was talking in general terms about the average patient. He was not talking necessarily about my mother. So, I realized I had to ask a lot more very specific questions, and that, in this case, it meant learning a lot about colostomies, how they might impact my mother's quality of life, and also, obviously, learning a lot about palliative care. So, it's now the last day in the hospital, and new doctor, and I say, yeah, my mom, we're thrilled to be going home, and Mom wasn't too happy about the options that were offered to her, so we're going to consult with a palliative care specialist. And lo and behold, he says, well, I'm a palliative care specialist. And I said, really? Well, maybe you can tell me. And I explained what the surgeon had said. And I said, my mother really doesn't want this surgery, but she really doesn't want to die an excruciating death. And he said, your mother is absolutely fully within her rights to reject the surgery, and she will not die an excruciating death. There is effective pain management for this. So we met with a representative of the hospice that day before we went home. And on later reflection, I started to think about the fact that our mantra had basically been do nothing. We didn't use those words, but we said no chemo, no radiation, nothing life prolonging. We didn't say, we want palliative care. We didn't affirmatively ask for it. Now, as we learned from my mother's amazing palliative care team, palliative care is anything but doing nothing. I mean, this was active, skillful management of her diet, her digestion, her medications. And the team not only kept her comfortable and pain-free, but living well enough to fully and actively enjoy what remained of her life. And when the end came, it was at home, it was peaceful, and it was pain-free. And having seen it up close, I just couldn't imagine that more people would not choose this option if they knew it was available. And it shouldn't take magic words to find it out. Okay, so, a couple of things occurred to me as needed to operationalize this so that more people are routinely provided with complete and meaningful information about palliative care. First, it's essential that all doctors who treat the terminally ill and even the very elderly have just a basic understanding of what palliative care can offer. My mother's, in a reenactment, my mother's surgeon should know enough to at least allow for the possibility that an excruciating death is not inevitable. Second, it would be great to have rounding, routine rounding by palliative care teams at the bedside of anybody with terminal or significantly life-limiting conditions. And fortunately, there are huge numbers now and growing numbers of resources to support doctors and hospitals who want to start this journey. Diane's organization is phenomenal, the Center to Advance Palliative Care. They provide tools, training, and technical assistance, and I listed some very cool resources that my agency's produced, and these are, there are many tools and trainings for improving patient and family engagement, improving shared decision-making, and these can be adapted for palliative care. And ultimately, what's most important is really vigorously applying the tenets of patient-centered care at the end of life. The end of life is not when we should stop being patient-centered, it's when we should be most patient-centered, which means elicit and accept as valid, even if they don't conform with your own goals and preferences, those of the patients. Ensure that there's a dialogue, ensure that that dialogue consists of information that is tailored to the expressed goals of the patient. and most importantly, recognize that a good outcome has to be the one that's defined as what is meaningful and valuable to the individual patient. And in my mother's case, a good outcome was living what remaining time she had to the fullest in her apartment, surrounded by her family and friends. And I'm closing with a picture of what an informed choice for palliative care looks like. So this is me with my mom and my daughter just a couple of months before she died at the Metropolitan Museum of Art, which was one of many, many, many excursions that we had. So thank you.
Well, it's difficult to go back to a technical conversation after that, but I think that's sort of the point of us having the narrative matters in this and other issues of health affairs. But it does lead me to ask, I realize that was focused on palliative, and we covered a lot of hospice as well as palliative in this panel, but I would be interested in reactions from the other panelists to the experience, not just so much what it typifies, because unfortunately we've all heard the stories of people who had to fight to get the care. The details are often very different. But what it says about the research you've done, the agenda to make it harder, to make it so you don't have to fight as hard for this sort of an outcome. Diane, do you want to?
I just want to point out what has been pointed out many times before, which is an advanced care plan will not save you. And there are multiple stories, just like Dina's mother's. And the problem is that unless you also have adequate clinician training and population health screening capability to identify people who are at high risk and who need this type of approach, and unless you have the capacity to deliver community-based palliative care for people who are not hospice eligible, without all those things, an advanced care plan is a piece of paper and it doesn't help you. So this notion, which I think is perhaps promulgated by lawyers who believe in pieces of paper that are signed and witnessed, that somehow that makes a difference, it just is a pathetic, frail read against the financial incentives and delivery models machine that patients find themselves in. That surgeon was practicing as he was trained. You know the people that taught that surgeon taught him that allowing someone to obstruct their bowel was an excruciating, tormenting death, and he never knew any different and was never saw any different. So from the best of his knowledge and ability, he was giving what he thought was the best advice. That is a failure of the medical education system, an abject failure of the medical education system. So whatever policy we develop has, and the federal government can't do this, has to influence how medical schools are accredited, how residency programs are accredited. It's a very complex series of levers that all need to be pushed at the same time to protect Dina's mother, who, had she not had Dina as a daughter, would have had surgery without any question.
I just want to say that it's not just that the piece of paper isn't enough. This happened in New York City, and I learned actually in writing this piece that New York State has a law called the Palliative Care Act, which requires counseling of all patients with terminal illness, the option of palliative care. And I couldn't figure out whether, because if she had the surgery, she wouldn't have been terminal, if somehow they didn't think she qualified. I've been meaning to ask someone.
They don't know about the law. The law is only a piece of paper.
There you
There's
go.
no
So
enforcement, so
yeah.
it's meaningless.
Other reactions, Susan?
I wanted to just mention the VA system. What I think was great about this initiative and their programs is that they did address the policy and they did address the staff development that is needed, and the program development and the collaborations with organizations. So I think other integrated systems may use this as a model to at least consider that it's the whole wide spectrum of issues or policies that are needed, policies, programs, training, and this has appeared to work. And another important piece that I didn't have time to mention is they do routinely quality monitoring in the VA and provide feedback to the medical centers on how they're doing. And this is continuing even though the funding for this initiative has ended, but that's an important piece. And so they can keep on track with these efforts and accountability. Yeah.
Building on those two sets of remarks, that to the degree that financial incentives or quality improvement activities are ongoing or need to be encouraged, including measures of patient and family experiences of care, and those are clearly perhaps I'm biased, but perhaps the most important measures to be assessing to ensure that in the example that Dina very eloquently gave to us, that care preferences are being met and the communication is clear and that care is responsive and so on.
Yes, I see two in the back.
Hi, I'm Mary Jean Schuman, George Washington University School of Nursing. Thanks to a grant we had from ARC a few years back, we actually did a lot of work around trying to have nurses foster better patient and family engagement in the system. And one of the things that I learned is that there is an opportunity to use the regulatory environment to help influence this change. And that actually nurses in some states can be reported to the Board of Nursing if they are not actively supporting patient engagement. That seems pretty drastic, but at the same time, when you hear this sort of example and you hear that you have a state statute that says X and Y should happen, it is another opportunity to try to influence the system.
Hi, I'm Joanne Lynn from Altarum Institute's Center for Elder Care and Advanced Illness. It seems that we really need two kinds of data that are mostly missing. You know, that orthopedist couldn't have been trained in what happened, or not, the surgeon, not an orthopedist, could not have been trained in what happens without surgery because we simply haven't described it for generations, I mean, since the Civil War. So repeatedly when I'm involved in some court case or something of the sort, there's a physician saying, oh, but if we don't do X, horrible Y will happen. And I'm left saying, gee, I don't know that'll happen. You know, I mean, I think I could probably keep it from happening, but you look at the whole literature and there's nothing out there. And when you try to do descriptive work, NIH and AHRQ both say, oh, we are interested in intervention work. We don't do descriptive work anymore. So we really need a push to describe. And I think especially we need descriptions that are geographically anchored so that they mobilize political action. You know, it's nifty to know that one nursing home has a high or low rate of antipsychotics, or that the VA is doing better or worse on something. But what really matters is what your community is doing, and are we getting better or worse for the average experience, and maybe the high and low experiences. But we don't do any description on a geographic basis. So no one knows how to act on the data, on what they see. They see an anecdote. We don't know how to generalize the anecdote. Was that one thing happening, or does it happen every day, all the time? So I'd really call on us to push for these two kinds of data that right now are really, really missing.
Well, there are some exceptions to that. I know there's been a lot of descriptive data on tube feeding in the nursing home, and I think that has changed practice, and I think Joan and Susan Mitchell and Vince and some others have shown that. And in the VA, they have done a lot of descriptive analysis, and they provide feedback to the regions, to the health medical center regions on how they're doing. So from that perspective, they do address that. But I do agree that other things like not doing colon surgery, perhaps we need more information on.
Well, it's been a full morning and into the early afternoon. Before you all stand up, I just want to say a couple of things. The first is, it's always a challenge when you publish a journal to know we want change, we want improvement, we see lots of opportunity for it. Vince reminded us He's been doing this for a few decades. What I feel we are able to contribute is to a literature that both puts concrete policy opportunities as well as some real success stories of how policy matters into the discussion, as well as some pieces that I'm confident will be referenced for quite some time, having to do with the nature of delivery and finance and some of the comparative work that I think greatly improves our understanding. So I don't think the world will change tomorrow, but even some of the papers made reference to situations where more recent data might show the implications of more recent policy change. So this is a dynamic area. We hope we've made a contribution to it. And before I ask you to thank our panelists, I do want to again acknowledge the support of the Gordon and Betty Moore Foundation for making this issue possible, and Vince Moore for giving his advice on the issue. Please join me in thanking our final panelists as well. And we are adjourned.